our communications officer, Owen, is playing today. And the youth voices are showing representative also streaming live the session today. Asante. So Evelyn, over to you.
October of 2022, hoping to end by March of 2025. And our funder was the Women Rights Initiative from the IDRC. So we had 4 study objectives. The first one being the study wanted to describe the impact of COVID-19 on women and male healthcare workers within the 2 counties, both the paid and the unpaid healthcare workers. And the unpaid in this case were the CHPs, and the paid and the mainstream healthcare workers within the facilities. The second objective was to examine the gender vulnerabilities that were associated with the pandemic, and then to describe the coping strategies that healthcare workers adopted during that time, both for the male healthcare workers and the female healthcare workers. And then lastly, to generate gender transformative and inclusive policy recommendations. As we have seen, the study was focused on women, and women being the main, but we also targeted the men. So the study method was a mixed method study where we employed both the qualitative and the quantitative methodology, and it was guided by participatory approaches. And the participatory approach that we incorporated into our study was the human-centered design and the GBA plus. So for the human-centered design, you being our participants, you were the key drivers of our study, and we wanted to implement this study while taking care of your needs. So that was the whole methodology of the study. So I'm going to share with you a short video that briefly wraps up what the WILA study is about.
WILA is an acronym. It stands for Women in Health and their Economic Livelihood and this and the emergency period was specifically during COVID-19. I know we've had several so this study was particularly important for us to gain understanding in terms of the architectural response in a lot of countries, but also what were the experiences of the healthcare workers in the response, how did they manage the disease itself, and how did it affect them?
With the WILA study, it has been, I would say, unique in that it has a participatory approach. And whilst that in itself is not unique, I think the WILA study seems to be unique in that everybody is saying that we actually have put our money where our mouth is.
The community that will be the end beneficiary for this, the products of this study are on board from the word go and are involved. So this is part of the study design.
Because previously the research used to be done and they never used to get disseminated. But now, once you're part and parcel with this study, the study gets disseminated and then the county can take the ownership to the research findings and see how we can be able to move forward with the findings of the research.
Research has predominantly gone the traditional way, where we go to the field, collect data, and then we leave our subjects just to give us data, then we leave them like that.
What I think other projects could borrow from WILA is the participatory approach of it, because WILA used this methodology and it actually involved all the stakeholders and mostly the participants.
WILA used a cross-sectional mixed methods approach. So basically what that means, we first did a quantitative data collection, then we moved to qualitative. So we used both numbers and experiences.
We just completed the quantitative and qualitative, data analysis, and we were sharing, findings from those studies, and we were just looking to have, a reaction, ideas, observations from the groups that we've set within the study, that is the Community Research Advisory Group and the Local Advisory Board.
This project, we were able to involve them from the word go. They are the ones who also informed the data collection tools that we are using. They give us the questions to ask. So it was a good experience.
And they were able to guide us on how to go about the study, on how to conduct the study, on how to go and collect this data. Like they will tell you, this question is good, but the way you frame it, you will not get what you want to get. So do this and you'll get this.
There's a huge cry and a yearning for community, which is comforting in a way, because you think that actually we all have this deep human need to know that we're not alone. And then the last thing is that they really want to know that change will take place. That change is going to happen, and it's going to have lasting effect.
We would like to see action probably out of this at the end of the day, and to have the top leadership within government take up key recommendations, and those that are implementable get implemented, and also other stakeholders, because it is touching on almost all aspects of the day-to-day life of a health worker.
Having a better structure on emergency preparedness that would not warrant us as a state to go into a panic mode, or what do we do? Like ideas, let's do this. A crisis, let's do that. We should already have the answers, like a manual. If this happens, we already have this. These are the structures, and this is what we are supposed to do. These are the partners, and this is how each of them will come together like a puzzle to just make things seamless.
I would really wish that the voices of the healthcare workers that came, what they told us will actually be heard, and people will do something about it. It shouldn't just end at the report. People, the county governments that we are working with, the Mombasa County, Kilifi County, as well as the National Ministry of Health, they should actually take up the report, do the
studies about. Now, if you'd like more information about the...
So, before we move out for tea, because it's already that time, I just have a few housekeeping things. When you come back, the way we're going to be sharing our findings with you is through theater. So there's a few important things. One, please, when you come back, can you make sure your phones are on silent? It's very distracting to the actors if in the middle of their scene, the phone rings. So just make sure that your phone is on silent. When you leave here now to go for tea, just switch it on to silent, please. The other is, the closer you are to the front of what's going to become the stage area, the easier it will be able for you to see the actual play. And the last bit is, they need to be able to move up and down the sides of the room easily for a change of scene. So if you happen to be sitting in one of the chairs on the end, you can just tuck it in a little bit on the side so that they're able to move freely. That would be really helpful. But those are the three housekeeping things I had to share. Bilali is going to share with you where tea actually is, because we have a tea break now before moving on to the dissemination. And if everyone can be back here for 10:20, that would be greatly appreciated. And I'll turn it over to Dr. Bilali to let you know where tea is actually being served.
Thank you very much, Lisa and Eva, for your presentation. Let's appreciate them. Yakilo. So before we just break for tea, I think there are two people that came after the introductions. We would like to give them a minute to introduce themselves, and then I will let us know where we're going to fill our tummies.
Good morning, everyone. Good morning. I'm Lois Nyaboke Nyachio, a community health promoter and a community health advocate. Thank you so much.
Karibu Kilifi. We hope you can stay here a few more days at the hotel to enjoy. Yes. Sir, kindly introduce yourself.
Habari asubuhi. Majina ni Peter Wanjoi kutoka Ministry of Health, Research Division.
Karibu Peter Wanjoi, tumpe makofi pia from the ministry, and this just portrays the importance. We need all stakeholders on board to be able to take in the findings. So tea will be served in the next building. If you go outside this building, there is another conference facility. Tea is served outside there. Karibuni chai. You are safe. Your items are safe. If you leave them in the room, they are safe. Oh.
Hata usijaribu kunishika. Sitaki msaada wako. Nasi, sasa nifanye usafi tu hapa. Hebu rudi kwa kazi yako. Nasi.
Chalo. Wanawake wamemkalia chapati mpaka sasa wafanya kazi zao leo. Vizuri sana, fanya bidii ili uweze kupandishwa madaraka, sawa? Haya, kuna wapaka. Chalo. Hapa pasafishwe sasa hivi na huyo akimbizwe wote. Nirudi nimuone hapa huyo. Kibarua kinatanyasa.
Sawa. nenda ufanye exercise. Yes. Nimeandikiwa dawa nikanunua. Na hizi dawa ni zile. Nani amekuandikia dawa? Madam, hii hapa ni signature yako. Sasa ndio umenipesa dawa. Ndio nataka kuongea vitu vingi. Na nimekwambia mara nyingi, ukija hapo unapewa dawa. Wacheni kuuzia wagonjwa. Sisi au hebu peleka mgonjwa kwa dawa. Sasa mgonjwa, mweke kwa nini? Achana na hii fine. Mama usinunue dawa kabisa. Sawa. Mimi ni wa serikali na serikali hawatoi pesa, mimi sijapatiwa pesa. Sasa nikuulize, yale majina yetu ni ya namba za simu zilikuanza lini kama profile kulipa? Si mnajua kwa kawaida huwa lazima tukifanya mkutano tuandike majina. Ndio nikiandika ripoti tunapeleka hospitali. Si ni kwani mnapofanya hospitali? Yaani hospitali karibu hivi. Lakini ndio kwa mashinani sisi hatutumii. Sio hivyo. Ongea sio rofa.
Madam unafanya purchase. Sasa tulimlipa sana. Hata mume wangu talipa. Kama chukua kuchalika basi na hiki tutaona.
Sasa unaongea hayo. Angalia mama. Wewe hata usiwe na wasiwasi kuhusu hawa. Sawa. Wewe ndio unataka nyumbani umefanya kazi nyingi. Wewe ndio unataka nyumbani.
Nenda nyumbani wapi? Sasa ile ndio wewe mkutano.
Wewe hupumziki.
Tutapumzika saa ngapi na kazi lazima tufanye?
Sawa, lakini hakuna shida. Maana hata kama nyumbani boda boda ziko, simu na pesa.
Sawa wapi? Unafanya kutembea kwa mguu baba.
Mguu.
Kwa nini?
Shida ni sijakuwa mzoefu kupiga laptop.
Ulienda shule tu ukaamua usome mambo ya laptop. By the time umalize kazi la stage kwa stop, utakuwa umejua. Kuna kitu kingine nasema lalamishi kwamba ufanye kazi vizuri.
Madamu hizi faili yenyewe. Alafu isitoshe mahali mliziweka ni kama maandishi mengine yaliyo wanafanya. Sioni vizuri.
Sasa nataka ndio tuuliza nafanya walikuwa wapi, walienda wapi. Mbona unataka kulalamika wewe? Si ufanye kazi. Wataka kazi au unataka kazi?
Nataka kazi.
Basi ufanye kazi. Sawa kijana?
Alafu kuna hapa naona mliweka rekodi mwisho kuanzia 1980 mpaka 2002. Sasa sijui kama mlikuwa mnakiangalia.
Na wewe wanataka kujana. Training zinakuja, campaigns zinakuja, nitakuweka hapo kweli kama ufanye kazi. Fanya kazi.
Tena.
Virus case in Kenya.
Hii mikutano yenu nyinyi CHV haina chochote, haina hata shilingi 10. Leo kuna mkutano wa bunge kichwa 300. Alafu kuna breakfast. Mambo ya twende kwa chai.
I want to inform you that the Ministry of Health has confirmed the first coronavirus case in Kenya. Coronavirus case in Kenya. Coronavirus case in Kenya.
Niliandika barua pepe lakini sijapata ujumbe mpaka leo. Kama serikali wametenda nimeingia nchini.
Sasa mimi nasema hivi. County government hawajasema chochote. Referral hospitals hawajaongea chochote. Nafikiria tuende chemistry. Tuchukue hizo pictures. Alafu tutazileta hospitali. Sasa wewe tekeleza.
Hata serikali
Kabla kuvuna tuwe tuko tayari. Unaelewa?
I'll make the adjustment. Na zikija KN95 sasa nafanya
that the Ministry of Health has confirmed the first coronavirus case in Kenya.
Yaani mama nimechoka. Unajua kuchoka mama. Yaani mimi ni wakosha choo siku. Nene ambazo zile blocks sijui wiki tatu zilizopita nisafishe mama. Yaani
ngoja. Ati washa.
Nisikilize. Wewe umesikia wacha? Watu kiti. Wewe umesikia wacha? Watu ambao wako unasikia mbele hapo kwa mstope baba.
Mimi huleta hapa, kama niliwaambia mkae barakoa yako. Barakoa yako kwa? Hivi kifaa hizo barakoa anashindwa kupumua. Unaona? Hivi kifaa hizo barakoa anashindwa kupumua. Unaona? Alafu nyinyi ndio mnasema kwa kuna corona na hamtaki kufuata maagizo. Mnajua tukiendelea kukaa vile tunakaa hivi ndio mtashikwa na corona nyinyi. Mimi nishawaambia kila siku nawafundisha na mnataka nizidi kuwafundisha. Nitazidi kuwafundisha sasa. Nishawaambia watu wazee ndio wako hatarini kuambukizwa. Wewe unazunguka huku ukikusanya corona utuletee huyo tumalize.
Nyanya. Tafadhali tuzingatie sheria ambazo zimewekwa na serikali ili tuwe salama. Sawa nyanya?
Nenda ndani sheria bila nufuru. Zimu na nikoroga sana. Nyumba nitaiwacha hivi.
Mama, kitu kimegoma hicho. Yaani nimesema hapa tosha.
Yaani wewe sasa kwa mimi kipata sana. Nasema na ngangana iko ni bai kabla chana hajafika lakini
Shako kwa maneno. Sasa afadhali wewe mama. Cheki maneno. Yaani nakwambia hili ukivaa kama una mwezini.
wewe bwana matania kutoka
Anyway, tafanyaje? Shale. Chai hakuna vile mama. Basi kama huko basi. Mimi niko na wazo sawa. Wacha niende kupiga ripoti yangu kwa hiyo ndio kazi.
Sasa ripoti usiana vipi na corona?
Ona. Angalia.
ameonyesha dalili zote za corona. Wacha nichukue maski na kusawa.
Sasa, unaona daktari wetu?
Sijamuona. Lakini sasa, wewe mgonjwa ndiye nani? Ameonyesha dalili zote za corona. Nina uhakika sasa.
Ukimwona Jeff mwambie sasa hivi namhitaji usimwambie sawa. Sawa.
Tafadhali waambie wabambani wakati muunganishe pale nyuma kwa hivi sasa. Lakini mimi hata sijui kufanya nini yani. Sijui.
Wewe kuna nyingine?
Nitaweka kwa sasa hiyo ndio wanafaa tumie.
Sasa mimi ndio. Ngoja. Rudi nyuma. Social distance nyuma.
Yes. Mimi N95 ziko na wewe zimatia. Ziko tao zinauzwa. Mbona mjanunua? Wala lakini ndio wazi hospitali inafaa kutupatia. Serikali haijatupatia kitu, tukapatia kwa nini? Sasa mnanunua tao, mnabana na kinga. Sawa mada. Yes, ya kwanza nafikiri umeipata tayari. Haya nasikia. Hatuna solution. Kwa nini?
Kwa nini?
Wewe ndio unafungua sio? Akili yako ifanye sio? Huwezi ukafikiria hata wale watu wao. Akili zao ziko sawa, ukawa karibu na wale watu wa TV, ukaweka mahali pamoja, ukataka ndugu, ukaweka wagonjwa, mpaka mimi nifikirie kila wakati.
Lakini madam, kama isolation room ni mtihani, sasa watu kama sisi ambao busy zimekuja zitutoshe. Nimepasua kama tatu.
Usiongee wewe. Mara ngapi nimekupata na chapati kisa wewe? Kila wakati nikukula. Na nikakwambia wewe leo utakuja kwa mgonjwa kwa hiyo hospitali. Sasa zikipasuka nataka nifanye nini? Daktari wewe na mwili wako.
Daktari Jennifer, wajua wazi sasa corona imeingia. Na lazima kuwe na usafi wa hali ya juu. Lakini hapo hospitali ilikuwa mifereji.
Charo bado inaleta maji. Mimina kwa mitungi. Sio kila wakati ni madam. Get back to work. Only hour.
We need to think on our feet.
I am thinking. Watumie hizo kwa sasa. Mimi sasa nimechoka. Hata kwa gani yenyewe.
Serikali pia tena.
Madam. Mimi naomba na bado nachukua staff wetu wanawapeleka waenda wakaangalia wagonjwa waliopatikana na COVID na watu waliotangamana nao.
Isolation room iko vipi?
Madam, sijawahi kuona hali kama hii. Hii ni hatari. Isolation room zimejaa na wagonjwa bado wanazidi kumiminika huko chini. Sisi tutafanya nini hapa? Vifaa hakuna.
Wajua unajaribu kufikiria tutafanya nini next?
Tufikirie njia mbadala na tukiendelea kufanya kazi kwa sababu hatuwezi kubaki kuendelea kwa hivi.
Sasa mnakuja kufanya nini?
Rema nimechoka, siwezi kuendelea kufanya kazi tena.
Sasa wewe ukichoka sisi tuseme nini Rahab sasa hivi jamani?
Rema nimepoteza wagonjwa watatu. Wagonjwa watatu ndani ya masaa 24. Rema mimi sijui ni nini nafanya. No. Sijui ni nini nafanya.
Rahab, wewe umefanya vile umeweza. Mambo mengine tumwachie Mwenyezi Mungu.
Rema uelewe. Tuna sacrifice maisha yetu kuhakikisha wagonjwa wanapata nafuu, lakini management yetu haioni. They don't even appreciate us.
Kweli management ni mbaya, lakini haimaanishi pia sisi tuwe na roho mbaya ama tuwe na uovu.
Raha. Twendeni mnisaidie kazi jamani, nichoka. Tafadhali twendeni.
Twende wapi hali huo zako amesema amechoka sasa hivi. Wewe leo unakuja unasema tusaidie kazi. Kazi ni nyingi ulikuwa. Lakini tujitahidini jamani. Huu ndio wakati ambao ni mgumu unajua. Lakini sasa bila sisi wengine wataweza wapi? Guys, angalieni wale wagonjwa wanazidi kumiminika hapa na wanatuhitaji. Alafu isitoshe sisi ndio tumebakishwa hapa. Lazima tujitahidi tuweze kupita hili janga. Mimi nimefanya kazi na nyinyi kwa muda mrefu. Najua capability yenu na najua mnaweza. Raha, Charo, we can do this.
Sawa.
It's okay.
Sawa, acha tuendelee kupambana.
That is the
Nenda lamu kuchukua majibu.
Sawa, nilikuwa na patient. Sasa mnataka kukimbia. Basi join huku kwa hao jamani tafadhali.
Bangwe! Bangwe!
Who is it? Hali yako?
Salama mzee.
Nandi? Mungu sijui zako. Vipi Kilifi?
Ndio hivi.
Umepita?
Ninatoka zangu Mombasa naja hivi. Moja kwa moja ndugu yangu. Hata wameka lockdown watoto wasiingie huko.
Umefanyaje wewe?
Pesa ndugu yangu. Pesa.
Umeroga?
Lazima.
Hivyo ndivyo kulivyo. Sasa mimi nikikuona wewe nakumbuka ule wakati tulikuwa tukipiga ngoma.
Wewe.
Ulikuwa ukisikia mimi ninapopiga kwa na wewe umeshika bumbumbu.
Una nini tena mwanangu?
Mbona sura imebadilika hiyo? Mbona imekuwa kama Ruto akionana na Gen Z?
Ndugu yangu. Wajua mke wangu bado anafanya kazi hospitali.
Wacha wewe.
Hiyo kitu inaniudhi kama kitu.
Mpaka sasa.
Anafanya.
Na hii corona. Uliwa. Wewe na mama mshapangiwa kuuawa. Yaani hao wanawaua live.
Yaani mimi sijui wanatafuta nini. Stop. I am speaking, stop.
Hapo mliposimama. Hapo.
Huko.
Yuko wangu cha.
Naam.
Usirudi tena kufanya kazi hospitali. Kaa hapa nyumbani mpaka corona iishe.
Nyanya hilo haliwezekani.
Nimesema tafute nyumba niende kabisa na usikuwe rudi katika nyumba hii.
Mtawaua hawa na corona yenu mnaenda kuchukua huko nje. Hamuelewi?
Nimesahau nyumba baba.
Sawa. Hata kama nyumba ni ya babako, sikutaki na sina haja na wewe. Haikuposi. Wewe. Kwenda ndani kwa kutekeleza.
Wewe chomongo. Ndugu yangu ushanichongea wewe. Mimi hapa na nyingine tunajua nyumba yako inajaribu kukutetea kumbe.
Jirani. Wewe umesahau wakati mlipokuwa na matende. Nani alikuletea dawa nyumbani kwako ukapona?
Sasa wataka kutangaza.
Na kuuliza nani alikuletea dawa? Mpaka mtoto akajifungua salama.
Kwani nimekataa mimi nimekataa.
Kuja na kwanza kuongea maneno mabaya kwa tu. Wewe unakuja kusema kwa nifukuzwe.
Mimi nasema saa ngapi ufukuzwe?
Kwanza barua yako kwa.
Mimi sishiki na magonjwa ya kijinga-jinga.
Hebu nikuulize, ulipotoka nyumbani ulijiangalia wewe?
Vizuri sana. Sema tu situmii kioo. Najitumia mimi mwenyewe.
Na ukapaa ukaona tu umevaa blouse na ukatoka tu na blouse yako. Toka na blouse yako hapa.
Unavaa blouse. Blouse kweli bwana.
Twende mama. Hii nyumba sina haja nayo na sikae tena. Kwa namna hii ni shida gani? Twende mama.
Ndugu wangu, hebu njoo tuelezee. Tuachane na huyu mwanamke atakufanya ushikwe na corona. Twende ndugu wangu.
Samahani nyanya, mimi siwezi enda na nyinyi. Siwezi.
Na wewe mwanamke, vile una roho hata huwezi kusema tubaki.
Twende mama, wasubiri nini? Acha nyumba yako.
Jamani, nini? Bada. Nilikuwa naja kujulisha mimi ni mjamzito. Congratulations. Asante. Kwa raha zako mwenyewe. Yaani corona ingia leo ingiza. Wewe unaona ni kama chote jamaa sasa hapa. Unachukua nini kwenda wapi? Umeona vile wakuta umeona kwanza hapa umejaa. Unaona? What? Wanaotumeona nani? Sasa basi madam, kama haitawezekana kuchukua leave, naomba nibadilishie department. Yaani wewe nikupeleke private. Mufanyiwe training. Bila ambavyo mtadili na watu wa corona. Kisha sasa nataka nikutoe hapo niweke mtu mwingine au wagonjwa wewe hospitali yangu yakuwe na wagonjwa wengi. Madam, isolation room umeiweka 7th floor. Lift ya hospitali imeharibika. Madam, naumia kupanda kushuka. Saa nyingine nasikia kisunzi hata siwezi kabisa. Na sisi watu tunaambia wewe na kuona kajua huyu mgonjwa anaita sanitizer. Mimi nitafanya kazi gani hapa? Kuangalia waizi, kuangalia huko kupanda kwa stairs, si exercise. Sisi tunaambia mama hapa wafanye exercise wakiwa wajawazito. Kwa nini usijiambie hivyo? Madam, naomba unisikize tu kama mwanamke mwenzako. Madam, mimi nikitoka hapa nikirudi nyumbani, nina majukumu mengine kama mama nyumbani. Kuna kufua, nipike, halafu mwanamume uliye naye ni bure kabisa. Yaani hanisaidii na chochote mpaka nikitoka nyumbani, nikija kazini, madam, na hii hali yangu nimechoka. Afadhali nikwambie kweli. Sasa mume wangu bure.
Muliniambia zinakuja lakini mpaka sasa kitu chochote kimeingia. Wagonjwa wanaingia hapa kila dakika na mimi sina enough PPEs. Hiyo nitashughulikia vipi? Sasa nikatiaje simu?
Madam, nilikuwa nakuelezaje? Kule kijijini wale wagonjwa wa HIV sukari wanataka kujua kwa nini hawaruhusi kuja hospitali, watapata vipi dawa zao?
Rosie, hiyo ni directive kutoka kwa government.
Sasa mbona mnabadilisha mambo bila kuisha sisi? Sio inakuwa shida kwetu sasa.
Nimekwambia ni directive wenyewe. Alafu isitoshe, sasa kuna pandemic ya coronavirus. Wewe twali na hiyo issue peke yake. Hizo issue zingine wacha zitasubiri.
Na je, zile PPE zimefika kwa sababu pia kule kijijini kuna wagonjwa ambao kuna corona inabidi tuwahudumie.
Sina enough. Zikija nitashare na wewe.
Lakini si una corona inabidi tuwahudumie.
Sina enough. Zikija nitashare na wewe.
Lakini si unajua ninasema tukuwe nazo kule wale wenzangu.
Rosie. Wewe ndio ni wagonjwa wangapi wanaingia kwa hospitali kila siku ndani ngoja mimi? Wajua ni madaktari wangapi wako hapa ndani si bado wanahitaji mimi? Sikiza, I really appreciate ile kazi. Sijui kwa nini unanipatia pressure. Hello? Kwa nini unanipatia simu? Nilikuwa nasema please, atachapia wagonjwa ni kuna pressure.
Halo baba. Charo, mbona jana haukuja nyumbani na ulikuwa umezima simu yako?
Mama, huku kazi zimekuwa nyingi, yaani nimekosa paka muda wa kuchaji simu mamangu.
Lakini uko sawa eh?
Nashukuru, sijui nyinyi huko.
Si tuko salama, tunashukuru. Nashukuru.
Mama bila shaka hapo ulipo na barakoa.
Baba niko na barakoa
Sisemi ya kitenge, maana najua unapenda sana vitenge. Uko na N95?
Baba niko nayo.
Vizuri.
Wewe uendeleaje huko?
Mama, huku mambo yamekuwa wasi zaidi kwa sababu idadi ya watu walioathirika na corona inazidi, watu wanafariki kila siku. Yaani mpaka nimeanza kupatwa na hofu mimi mwenyewe nitaenda kuambukizwa.
Baba usiwe na hofu kabisa. Mimi nakuaminia kazi utafanya. Nilikuambia tu muhimu ni ujichunge usishikwe na corona, sawa?
Ni sawa sawa.
Wewe fanya kazi baba, hudumia wagonjwa, usiwe na uoga kabisa. Ni sawa sawa. Alafu sikia, wakati wote ukiona kama wataka kuzungumza na mimi nipigie simu tu, ni sawa?
Ni sawa sawa. Angalau sasa maneno yako yamenipanguka kuendelea na kazi. Kabisa.
Haya sawa baba, basi tutazungumza.
Sawa, bye mama.
Haya baba.
Nakupenda.
Hata pia mimi nakupenda baba.
Haya.
Daktari. Samahani daktari. Mbona nasi zinapeleka karantini? Kuna shida gani?
Watapelekwa karantini kama watakuwa hawajaona COVID?
Lakini daktari, nimeona anapelekwa karantini for 14 days daktari. Tuko kidogo kwenye
Sasa hiyo ni sheria. Mtu yoyote ambaye ametangamana na watu wa COVID lazima apelekwe karantini kwa siku 14.
But 14 days ni siku nyingi.
Sasa tutafanya nini?
Sasa imagine daktari hawakuonekana hata na dini yote. Alafu bado unapelekwa karantini.
Lakini wametangamana na watu walio na corona. Familia zao
samani. Basi sio kwa karantini alafu tukumba kidogo au wengine nao wanasema watakata kupimwa sasa kama hali itakuwa inaendelea hivi.
Ni sawa. Huo ndio mwongozo serikali kuu imepeana. Lazima kila mtu apimwe na mkikata kupimwa mtakatupa mishahara yenu.
Mishahara tena madam?
Yes. Tu vile wamesema.
Serikali. Ikiwa mtu atakataa kupimwa, sisi hatuna budi.
Sasa
tuendelee kufanya kazi kwa
kazi cha kutosha.
Mimi nimechoka. Kwani Elizabeth, bado kwa isolation? Kwani nyinyi mwaniona sasa hivi? Nilirudi tangu jana nikarushwa tena 12 hour shift. Hata ndo natoka hivi sasa. Lakini kwa nini daktari Jennifer ya kufanya hivi? Na tulimwambia kwa wewe ni mjamzito. Kwani afichika tena?
Mimi ndio maana huwa nasema na nyinyi kila siku. Hii management yetu ni mbaya. Yaani ingekuwa na uwezo ningeifuta kazi yote.
Elizabeth, fanya hivi. Wala wewe hata usijali. Sisi tuko hapa na tutakusaidia. Sawa Elizabeth? Ikiwa labda kuna kazi yoyote ya kushinda, mimi na Rema tutakusaidia. Sasa yosema mimi ndo nilienda training, lazima niwasaidie nyinyi. Wewe usijali, sisi tuko pamoja Elizabeth. Sawa, usiwe na wasiwasi. Ndio. Acheni nioshe mikono. Amenituma tena kule ambapo lift ziliharibika.
Kuosha mikono na mfereji gani? Mifereji haifanyi.
Kumaanisha nini?
Tunangoja
Hakuna maji hapo hospitalini. Lakini mbona mimi hospitali imenitokesha jamani? Hakuna maji. Lift ni mbaya. Elizabeth.
Daktari.
Yes, mheshimiwa.
Ule upuzi gani ambao mnanifanyia?
Upuzi?
Nimepatiana maelekezo. Mmenipatia results za mkoa wangu kwamba iko positive. Nimewaambia
naomba kwanza kwa barakoa yako.
This is not important. Sawa? Hii si muhimu. Nataka results zangu. Nipatieni results za mkoa wangu kwamba iko negative. Nataka kwenda kuzika. Tafadhali.
Mheshimiwa, huyo unayemzungumzia amepatikana na virusi vya COVID-19.
So,
na kwa wakati huu serikali ndio inachukua jukumu ya kuzika hao watu, sio mtu binafsi.
Okay?
Na hiyo ni sheria.
Sawa, ni sheria. Ukizungumzia serikali unazungumzia nani?
Nazungumzia serikali.
Serikali ndio sisi. Ukizungumzia sheria, mimi ni miongoni mwa watu ambao tunatunga sheria. Sawa? Mimi ndio mbunge wa eneo hili lote. Na kwamba unifanye kitu kidogo nashindwa, ama shida ni mimi?
Shida ni sheria ambazo ziko.
Sasa
niambie iwapo tutakupatia huo mwili uende ukazike. Ni watu wangapi ambao tutahudhuria katika hao mazishi? Tutakuwa tumehatarisha maisha watu wangapi mheshimiwa?
Sawa. Unaitwa daktari nani?
Daktari Sani.
Unapenda kazi yako?
Mimi napenda kazi yangu sana. Ndio maana sitaki mambo kama haya yafanyike.
Sasa wewe nakuona una jeuri nyingi sana. Kitu kidogo tu nifanyie. Mimi nafanyia bidii kule, naenda nikaongee nini kwa bunge, mletee vitu katika facilities zenu, alafu mimi kunifanyia kitu kidogo ndashindwa. Let me tell you. Kwa sababu yako wewe, hii facility itaenda chini na kuhakikishia. Pili, no. Si umejifanya jeuri? Pili, na kuhakikishia kwamba leseni yako itakuwa revoked immediately.
Sasa huko tuafika
wapi? Na ikitokea kwamba kumetokea sababu za hapa na pale haiko revoked, nitakupeleka tu katika dispensaries ndogo ndogo. Wewe si unajitapa na daktari kwa sababu uko katika referral hospital. Nitakuonesha.
Mheshimiwa, tunaweza ku
Daktari, ujui unacheza na nani? Jua kuishi na watu. Nasikia habari jamani, vipi waendeleaje?
Usiniulize vile nasikia wenzangu. Usiniulize mimi. Ai. Nasikia uchungu.
Pole mama, pole.
Nasikia uchungu. Ai. Afadhali ningesikiza hisia zangu. Ningesikiza hisia zangu mimi. Angalia sasa. Mimba yangu imetoka. Anapo mume wangu ameniacha.
Elizabeth, pole. Haina haja ya kumkufuru Mungu. Hiyo sio mipango ya Mungu. Sawa Elizabeth? Rema, hata nisakukwambia. Jana nilienda nyumbani nikapata mtoto wangu ameachwa nje kwenye baridi na majirani wamekata umeme. Yaani mimi kinachoniuma zaidi, tunajaribu kusaidia jamii yetu ikae salama lakini wao hawaoni. Majirani zangu mimi wamechukua tu, yaani wanataka kunifukuza nyumbani kwangu kwa hofu ya kwamba nitawaambukiza corona. Hiyo ni haki kweli?
Si haki, raha. Na ndio kitu kilikuwa kinanitatiza kila siku. Yaani sisi tunafanya kadri ya uwezo wetu kusaidia hii jamii. Lakini jamii yenyewe haioni kabisa. This is too much.
Guys.
Hauna nini?
Kuna nini Charo? Charo, speak. Kuna nini?
Yes, Dorina amefariki.
No.
Nilikuwa naye jana kwa isolation. Nilikuwa na moyo endelea vizuri.
Upungufu wetu wa oxygen tumepoteza na Dorina.
Kwa nini Nasdorin? Nasdorin alikuwa nasi mzuri sana. Nasdorin amekuwa akitusaidia katika kila jambo hapo hospitalini. Nasdorin amefanya nini kudeserve hivi vyote?
Exactly. Kama Nasdorin mwenye alikuwa makini kwa kila anachokifanya na ameweza kuathirika na hivi virusi. Sisi ni kina nani? Sisi ni kina nani tusipate hivi virusi? And by the way, Raha, uko na kuna chini ya brother-in-law ambaye anaweza kuaccess hizi gears za PPEs. Kindly, mwambie atusaidie. I know you can do this. Kwa sababu management imeshindwa kufanya kazi yake.
Yeah.
And if you don't do this, tuko katika risk ya kupata hivi virusi. Please, Raha.
Rema, I'll see what I can do. Lakini sasa hivi nahitaji kuwa peke yangu.
Daktari.
Yes.
Yaani sielewi umefanyaje?
Mheshimiwa, sasa wewe uko parliament kwa sababu yetu.
Yes.
Ukija hospitali kwa nini ni kwetu? Sina kutengenezea mambo uende zako kazini.
That is too fast.
Kwa sababu yako tu.
Kwani kuna watu wako
Ni mimi kusema.
Mimi niseme tu nakushukuru daktari.
Asante.
Unajua nimeenda katika hospitali nyingine hapa wamenihangaisha.
Wale hawajui kusaidiana. Wajua watu ni kusaidiana.
Sasa daktari,
Yes.
umeniambia ni Jennifer.
Yes.
Mimi nataka tu nikuhakikishie kitu kimoja.
Yes.
Hii facility yenu itakuwa miongoni mwa facilities bora zaidi kwa nzima.
Mheshimiwa, asante sana.
Karibu.
Sasa nilikuwa nasema
Yes.
tuko level 4. Tunaweza kuwa sisi ndio referral.
Sasa ikiwa kumenikuna, kwa nini nisikukune?
Mambo ni mkunano.
Mambo ni mkunano.
Asante sana mheshimiwa.
Sasa Morris. Yes sir. Uko na ile badge?
Mheshimiwa, nyinyi mwende salama, msafiri salama, mfike vizuri. Na bado tunakuhitaji. Hiyo ni yako.
Niko na
hizi ni local, hii ni international. Hizi ni za wenyewe. Safirini salama.
Asante sana.
Sawa sawa.
shikamoo.
Marhaba mwanangu.
Mama, mbona unaongea hivyo?
Nilikuwa nataka kuambia.
Naam.
Nimepimwa, nimepatikana na corona. Baba niko isolation
Mama, wapi? Hospitali gani nije hapo sasa hivi?
Sikiza baba, hautakubaliwa kuingia baba. Wacha tutazungumza baadaye, sawa
Mama, niambie uko wapi tafadhali. Samahani madam, samahani. Naomba japo dakika 20 tu niende nikamwangalie mamangu hospitali, amepatikana na corona.
Kwa sababu gani? Kwa sababu gani unaona tuko na shortage ya manase hapa, wengine wote wamekuwa quarantine?
Lakini madam, mamangu yuko peke yake mahali yuko.
Mahali yuko na wahudumu kama wewe. Wewe unaacha wagonjwa wako unaenda kwa sababu gani? Mimi mwenyewe nyanyangu amekufa, sijaenda kumzika. Unasikia nikiomba ruhusa? Siombi ruhusa.
Lakini madam, tafadhali naomba kwenda hata kama ni lunch time.
Sikiza. Hapa tuko na nurses kidogo. Hakuna mahali unaenda. Na ukienda huko na tuko hiyo corona huko tulete hapa. Tuzidiwe kabisa. Hakuna mahali unaenda tano.
Madam, mimi nimehudumia wagonjwa wa corona ni muda sasa. Kwa hiyo tunajua kujichunga. Tafadhali madam.
Excuse me madam. Samahani, lakini kuna kitu kwanza ndio maana kimetuleta hapa. Kwa nini Dissemination haiko kwa isolation? Mbona kila siku ni sisi?
Dissemination inaletwa na mheshimiwa. Wewe kuja na nani? Na mheshimiwa amesema hataki kumuona mahali popote karibu na hizo corona. Kuna lengine?
Kwa hivyo pia tukipata connection na mheshimiwa tutapata hizo favors.
Lengine usipokula chapati kisa unafikiria.
Sawa. Another thing is asubuhi nikipita na boyfriend yangu akitoka nilikuwa na polisi. Najaribu kumuingiza ndani nimhudumie, but wameninyima access. You need to know vile tusaidia relationships zote zimeingia kwa hospitali tuhudumie.
Leo unajua unaniingiza kwa relationship zetu. Huyo polisi akiwapiga huko afanyaje? Mimi ni mhudumu hivi penye unaniongelesha, si ndio? Ndio maana akapigwa. Kuna lingine?
Madamu, inatosha. Inatosha madamu. Siwezi endelea kufanya kazi katika mazingira kama haya. Nimeacha kazi.
Finally, hata mimi katika mazingira haya na viongozi kama yeye siwezi kufanya kazi and I quit.
Na wewe?
Wataka mimi niende wapi? Madam Jennifer, wataka mimi niende wapi hali wagonjwa wananihitaji zaidi wakati kama huu? Dr. Jennifer, you need to do better.
Ningefanya nini tofauti?
Ningefanya nini?
Nilijaribu
Walikuwa chakula.
tungejipanga vipi?
Hebu tuwape makofi. Swali la kumalizia polisi, tungefanya nini? Na tuweke tunaingia kwa dawa hii. Nimeona wengine mpaka naanza kutikisa kichwa. Hivi ni vitu vinafanyika? Au ni sisi tumtunga vitu vyetu? Swali ni kuuliza, tungefanya kitu gani? Because hivi ni vitu vilivyokuwa vinafanyika na tunavizungumza kwa sababu vilifanyika, na tuko kwa wingi hapa kwa sababu ni research ya nyinyi mliozungumza. Ni kweli, ni uongo? Hebu ni mkono kama yani kutendekea hapa. Ni kweli alitokea? Hebu niambie, ulijifunza nini wakati hayo yote yalipotokea? Au kwa wakati ule ni mambo gani ambayo unaona yalifanyika yamefanana na haya? Ni mambo gani yamefanyika ambayo yamefanana na haya? Nimeona mkono hapo nasema yalinitendekea. Ni yapi? Nataka kutoka leo tuanze kujifunza Angalia Way Forward. Ndio sababu tumekuja hapa. Maana jambo kama hili si linaendelea. Na kesho tuko prepare. Sitaki tuwaseme tuko prepare leo, tuko prepare. Lakini likitutokea tena tutafanya vizuri zaidi. Lakini swali ni mambo gani yametutendekea? Madam, hebu niambie, ni kitu gani kimefanyika? Umenyoa mkono hapo kidogo.
Mimi kwa majina naitwa June Mogo, ama CHP hapa Kilifi. Yale ambayo mambo ambayo yalitendeka during that time as a CHP. We were given the activity ya identify people from the community. So why we don't have the PPEs? Ama even the training yenye ulienda, kuna yale kiasi labda mlisoma, lakini yale yenye mnafanya that beyond our limits. So at the same time mimi sikuwa nalipo wakati nimepatikana na jambo la kwamba nimepewa hiyo initiative ya kuangalia ama nimetumwa kila siku kumwangalia yule mgonjwa mwenye yuko mtaani. Wakati nimegojeka, hakuna mtu anasimama kwa niaba yangu. Inafanyika. So it is very painful na sijui kama tutafanya vizuri ama ndio ilishia hivyo.
Tunapozijua tutajua ni namna gani. Nimeona kuna mama mwingine pale wakati nazungumzwa, alikuwa anazungumza. Nitakupa sasa hivi. Nimeona ule mchezo umekuwa affect sana. Hebu niambie ni wapi pamekuwa affect. Maana nimekuangalia. Niambie ni kitu gani ambacho ulikuwa unakifikiria wakati tunaendelea na mchezo?
Mimi nilikuwa inanitatiza sana pale. Lakini ni kama na hivyo ndio.
Jambo ni kwa hivyo, kwa mnaeleza na hakuna mtu anakusikiza. Na ukiangalia hivyo kuni maksudi kuna mkono kwa kumenuliwa. Hebu niambie kwa kuna tueleze.
Mimi mahali ambayo imenigusa ni pale kwa Charo ambaye is a trained nurse. Fanya usafi. Kwa hivyo sasa nafanya kazi kama nurse, nafanya kazi kama mfagiaji, kama msafisha choo. Coming to COVID, pia tulikuwa na transfer of duties. Most of us healthcare workers tulitoka kama kazi zetu kwenda kuman roadblocks. Kwamba tuweze kuona kwamba watu kutoka kaunti zingine hawaingii katika kaunti yetu, ambao sasa kwa kesi fulani ilikuwa hivyo kwa muda mrefu na kitambo hiyo ilitokea.
Nafikiri kuna kansela mwingine amekuwa kazi ya kutoa zile maiti. Tulizungumza naye nasema tulipokuwa kazi yetu ni kupanda ghorofa ya 6 ya 7 huko. Tunaenda kwa gaba, zetu hadi zile bags unateremka.
Whatever we have been able to witness, some of the things are still real and they are still happening. Indeed, there is still staff shortage, which is currently biting. Again, during the same COVID pandemic, we lost healthcare workers, and there is no elaborate way to actually offer compensation in terms of the said losses, and that impacted negative to the families. So again, lack of preparedness has really come out in the way services were being managed then. And I think moving forward, lessons were learned, and we can do better in view of managing these outbreaks in case they arise.
Anasema tunaweza kufanya better. Nataka kuna daktari wangu hapa nimemtaka. Huyo mpe baadaye sitaki. Kuna daktari wangu Emma pale. Tulikuwa prepared wakati tunasikia inatoka. Maana tumeanza kusikia iko wapi? Iko China mpaka hivyo. Were there any preparations ambazo ulitayarishwa kujua kuwa ikifika hapa ni hivi ndio tutakavyofanya?
Wakati COVID iliingia kwa country, nilikuwa KCH, nikiongea nasikia ni kama note ile experience about apart from preparedness, ile experience ambayo ilikuwa ngumu, people were taking oxygen in the casualty department seated in a sitting up position. Unaelewa nikiongea hivyo? Yaani vitanda vimejaa kule kwa isolation ward. My administrator is here, Mr. Msau. Tungepiga simu kule isolation kumejaa, casualty kumejaa, hatujui tufanye nini. Wagonjwa wengine wako wanangoja vitanda, they are taking oxygen kama wamesit. It was not a good experience for us like nurses. Yani ilikuwa inatupatia burnout. So we could have to wait mtu adischargiwe in the isolation for us to take other ni kweli tulikuwa tunangojeana, although there are many centers but the centers were all full, kama vile walikuwa wanasema isolation centers zimejaa. So ni mtu akunywa oxygen. We are trying to help people taking oxygen while they are seated na vitanda zote zimejaa. It was a lot of stress. Asante. With more other experiences.
Huyo staki sasa hivi nataka kuja hapa. Hebu tuambie experience yako ilikuwaje? Wewe ni muuguzi au ni hebu niambie ilikuwaje?
Okay, my experience was a bit different because COVID ikikuja, we were in school. Schools zikaambiwa zifungwe, workers wote warudi kazini. But immediately we came back, we were taken to the isolation centers. So mimi ndo Saturday ndio ilikuwa imefunguliwa. So kabisa
it's an emotional thing ambayo tunazungumza na tunataka tuzungumze because this is the only place we can talk. Tuko watu tofauti hapa, tunajua wakati tunazungumza message hivi. I'm sorry, lakini tungetaka tujue tu how was it so that we get the true picture, tuangalie isirudike.
So it was a new center which was not fully prepared. When we went there, I think chakula tulikuwa tunaletewa na Mombasa same.
Nataka kidogo tupumzishe ili baadaye tu. Nataka kuuliza tu daktari hapa. Kwanza kabla sijaenda mbali. Daktari, how was it in Malindi? How was it in Malindi? Was things better? Kushinda hapa Kilifi maana ni nguli ilikuwa tu.
First of all, in regards to Malindi as in the catchment area, people are flocking in place. And as a play confusion with every guideline. And personally, I'm a dentist by profession. Yeah, so everything had to come to a complete stop because the mouth is the window to the body. We breathe through it, we take things into it. So we had to stop because there were no guidelines at all. And at the fertility level, we were overwhelmed. Our catchment area is as far as Northeastern Province, as far as Lamu County, as far as Tana River. So it was overflowed due to referral of such cases. Thank you.
It's quite hard. Nataka kupole tena nitakusumbua. Nimekuona vile huko, lakini nataka kuuliza. Kuna problem ambayo tuliona hapa inatokea. Ya kuwa tunakutazamia wewe pale hospitali utusaidie. Bado hapa family kuna risk ya familia yako. Kuna wengine hata kwa bahati nzuri au mbaya yule ambaye ni partner wako si daktari. Je, ilikuwaje kwa upande wako kifamilia?
Personally, it was a very, I can say, difficult or challenging situation. But then I work at that time I was the nurse in charge. So the guidelines were disseminated. Human resource is also as it has been seen in this scenario. Commodities also are erratic. There was erratic supply of commodities. So unakuja kazini, ulikuwa to work. But when you think also of the community, watoto wako nyumbani, the community wanakuona wewe
to you, ulipokonaje? Kuna wale wametoka sajanaji ambapo ni mambo kama how are you feeling about that?
Actually,
Sisi ambao tuko huko tena tunasema tulipokuwa huko CHP. Sisi CHP naita CHV kwa sababu time yao ilikuwa ni V. Haikuwa ni P. Wako wapi CHPs? Mama, nakuuliza tu. Waenda kuangalia hospitali hakuna PPE. Wewe ulikuwa unafanyaje kazi yako?
Kusema kweli hali ilikuwa ni ngumu, na vile ambavyo tuliona hapa katika hiyo scenario, CHP sisi tunashukuru imegusa ni hapo kwa yuongea na nas, yuamwambia leo kuna mkutano na yuamwambia mkutano gani ni ya bure. Twende ukaimeshea. Na isitoshe mimi ndio kama kuambukizika ni rahisi. Sipewi chochote. Tulikuwa tunasaidiwa na gloves. Na kwa sababu ni kazi yangu na ni jukumu langu, lazima nisaidie community. Tulipitia hali ngumu, lakini pia Mungu alitusaidia.
Hebu niulize, ni nani ambayo alipatikana na corona that time? Yuko? Tuko na mmoja ambaye alipatikana na corona at that time. Nyuma. Hapa. Hebu nipe mic. Wewe ni healthcare wako. Umeshikwa na corona. Hebu niambie what was it? Yaani unaona ni kitu gani kilifanyika mpaka ukafika at that position? Zungumza na lugha yoyote. Maana najua ulikuwa fikiria Kiswahili nitaweza.
The bad thing about getting COVID, personally, nilipata juu niko hospital. Tunatangamana na wa. So the same lift they use, the same lift I'm using. Alafu vile ilinipata sikujua like ni COVID. I think kulikuwa na ile mimi ni staff sizipata. Yeah, then baadaye unapata au unasikia vibaya. Hauko sawa kabisa. Alafu immediately you are diagnosed. Unapigiwa simu nyingi, habari Nancy, mimi napiga kutoka no, but they have the government has said we are going to record this nini wanaenda.
Kwa nyumbani?
Yes, my own people. Like
hata ukisikia watoto wanapigana huko nje cannot do it.
Hawataki mtoto ambukiza. Like it is in my house. So for a whole 14 days alone.
Na imagine mimi ndani ya room.
Yes.
Siku 14.
Siku 14
Joana anapiga kelele kule mimi sijui.
Hakuna kutangamana na wao. Alafu simu nyingi tu unapigiwa, the more you talk, the more you cough. It is a horrible experience. That's what I can say.
That's a health hold. Na ulipata support gani? Please, support to
support like again tulikuwa tunapewa inaitwa nini nurses oximeter. Tulikuwa tunapewa hiyo mashine.
Hebu nieleze maana mimi kisikia oximeter.
Inaitwa nini hiyo ya kuweka kidole? That one. Walikuwa wanatu offer for free and then you record and then they would call you every day to check up on you. Ikizidi I would just make a call and ningepata jinsi ya kwenda hospitali kuangaliwa. Juu mimi ni staff. Sijui about other patients.
Kuna CHP ambaye pia kwa bahati mbaya alipata corona. CHP. Nataka tufanyie comparison. Unpaid workers. Kuna mkono hapa. Because yule anasema kidogo alikuwa amepewa oxy.
Ile naweza sema concerning the CHP ungeshikwa lakini hata haungejua kwamba ni aza by that time. It was new, na wakati tulienda tufanye thorough cleaning kwa ile building tukapata kulikuwa na wagonjwa. Now ungeingia kwa ule mlango, hata kutoka haujui ungetoka wapi, na hizi manguo zako ungeziacha mahali. Natoa nguo zote alafu mnapewa hizo PPEs. Sasa kuna mahali mtapitia huko, unapitia mahali mnaambiwa muoge, kuna maji mnamwagiwa tena, alafu unapata nguo zako ziko huko mbele. So tunaenda tukiwa uchi hivyo online, tunaenda tunafika mahali tunatoka huo mlango unapata hapo kwa hiyo room nguo zetu ziko hapo. So na wewe unaanza kuangalia umetoa mpaka panty, imagine. So unavaa alafu sasa unatoka. Just imagine mali nitaenda nimekodisha room. Niko na mtoto. At the same time niko na sister yangu. We have one bed. Ukifika kwa ile nyumba mtalala na wao pale. So labda nina cough ama na sneeze. Wakiwa wamelala umekaa unawaangalia. So nikilala hapa ni kama nitawaambukiza ama itakuwaje. Get to know tomorrow you are going back to the same place. So ikafika mahali unakohoa, unatamani ukifika nyumbani ni saa 5, unakohoa, una sneeze, na kwa sababu sasa unaona ni kama ni kitu lazima nifanye, you just go there. So after imetulia, I became sick na nikawa admitted. Nilipokuwa admitted another hospital hapo inaitwa Wananchi. Hawakusema kwamba I'm suffering from COVID. Lakini kwa sababu ilikuwa sasa ni kama ni gonjwa limeingiliana na the symptoms are just the same. So inabidi tu your family, if you have a family then, wao wajukumike, waone ni vipi watakusaidia. Wakati ile memory bado inakuja kwamba yale nilipitia. Now, where are these people wenye walisimama kutuambia tufanye wakati nilipitana na mwenye alikuwa ni mgonjwa na how supposed kushika even kwa wall, how supposed kushika kitu chochote. Even the PPs as you undress them, kuna vile unatumia hiyo nini, mara unashtuka kwa sababu niligusa mahali na ninahisi kama iliniathiri. So kwangu mimi it took almost kama 4 months kitambo nikubali kwamba haikuwa COVID, lakini niliangalia nikaiona tu the symptoms na ile training nimeenda, this was COVID, though my family was safe. At the same time I had kwa community yangu kwa sababu kulikuwa na wagonjwa. Most of the people wanao work for the county wamenunua mashamba huko na wanaishi. So naambiwa tu pale kwa fulani. Sasa inabidi wewe kila siku pia unafuatilia wewe mwenyewe ukiwa vibaya, bado unataka kuconfirm, you call your chief mwambie kweli report iko hivi na hivi. So those are the things tulikuwa tunapitia na for real, si kama ni vitu zilituishia, mara zingine unakaa unaifeel vile vizuri kabisa. Thank you.
Mimi si realize kuwa kuna watu waliokuwa hiyo shida. Mimi kwa tunajua tu kutembea tu tujificha. Hebu nakuuliza tu. Are we prepared now? Nataka kuuliza Madam Luganje. Kabla sijakuja. Was there any special consideration for those people kwa na conditions fulani? Ya kuwa mimi ni health worker, lakini niweze kuwa exempted kufikia hapa na hapa na hapa kwa sababu either Kalume niko HIV, either mimi mwingine niko diabetes, mimi niko na condition ambayo inanifanya ninakuwa vulnerable zaidi. Were there any special considerations, especially for the ladies?
Ninashukuru kwa kuuliza hiyo swali. Katika ile drama tulimwona ile nurse ambaye alisema alipata ujauzito wakati wa COVID. Sawa, ilikuwa ni kwamba aondolewe akafanya kazi mahali kwingine. Ni kweli kabisa kwamba wakati wa COVID kuna watu wengine ambao hawangekubaliwa kufanya kazi katika isolation centers kwa sababu ya ile hali ambao walikuwa nayo. For example, kama umesema HIV, wagonjwa ambao wako na diabetes, wagonjwa wote ambao wana ugonjwa ambao unapunguza immunity, kinga yao ya mwili, walikuwa wanaondolewa, na watu wazee pia walikuwa hawakubaliwi kufanya kazi hizo. So there was a special consideration even amongst the healthcare workers for people with certain conditions not to work in the isolation areas. There's one thing I also wanted to comment, the issue of there was so much stress. Mliona wale wa healthcare workers vile walikuwa wana a lot of burnout, a lot of stress. So me being in management at that time, nakumbuka our first healthcare workers ambao tuliwapeleka Jibana. Sikumbuka kama ni the first group or the second group, walipata burnout. So walikuwa wakimaliza kazi wanaenda ilika kwamba spraying is dangerous. Tulikuwa tunawaspray kama vile anasema isolation centers, baadaye tukaja tukabadilisha. So policy kept on changing. So this issue of social support ilikuja after the first group walipotoka isolation, tuka realize there was a gap.
So psychosocial support ikaongezwa as one of the packages that was mandatory who went through the isolation area center. So it was quite an experience. Come on, I relate with the yule hospitali nzuri. Kulikuwa na ile hospitali mbaya, the one who was managing badly and the one who was really managing well. There's a time she started off well, akaweka isolation center, akapanga watu wake, they were ready for the patients to come. Lakini kufikia mwisho, she also broke down. So burnout is real. And unless you deal with the burnout, you give support to the people giving the care, you will lose it. And I'm happy because we realized it within time and we were able to support them so that they could continue giving their care. It was an experience and a half, but I think right now we are more prepared. From where I sit, I think we are more prepared. In case we get another condition that comes, we shall be better off to take over. Thank you.
Asante sana. Nataka kumuuliza one of those participants. Kuna mkono. Yeah, sorry.
Okay, thank you very much. I don't know if I'm too early, but I wanted to say something about the play itself.
Hakuna time iko early.
Okay,
this is the right time.
Okay, so first thing I want to congratulate you because I can understand how hard it was doing the creative brief. It must have been very hectic, and also doing the scripting. I can see the choice of cast is very good, the stage management was very good, and also the costumes are also very nice. It was very good. And I can also see you are fusing three things at the same time. There was drama, there was the mainstream theater, and there was also magnetic theater. Although naona magnetic theater umeileta mwisho.
Saidi, kazi umekosa.
Sawa. Also, I would like to comment something about the stage management, because basically during the play, I could see you were using the center stage more. The lower right and the lower left were not being used properly. So I think maybe in future, when you want to do your punchline, you can use the strongest position to project your punchline.
Thank you.
Okay, thank you. Otherwise, it was a very good play, nice choice of, and even the intermissions too. The use of the voices to enter and to leave the stage, the intermissions were very, very nice. I think it's something very good. Yeah, maybe if I have to say something, if it was me who was doing the creative brief, this play is not very short. It's a very long play. So I think maybe you can fuse it, the interjections, you can use the magnetic theater that you are using right now to have a participatory feel with the audience. You can pause the questions, maybe 1-2 minutes, you interject with you relate with your audience, and then let the play proceed. And when you're doing that, maybe you can freeze the cast and then unlock it to proceed. That way you're going to create a synergy between you and the audience. There's going to be a participatory nature.
Good. Sawa. By the way, the creative, we want full forum theater. A full forum theater, but tumeangalia hawa ni waheshimiwa. Kuwaleta kwa stage itakuwa si sawa. So there are so many things you are considering, looking at the audience that you were expecting to get. Sawa.
Okay, thank you very much. The theme of the play was so nice, and I don't want us to delve so much into discussing how it was supposed to be done. But what really came out was very clear regarding our experience as healthcare workers and family members during the COVID-19, particularly the lockdown. I don't know how strong I am to really talk about this, but I know being in the CHMT then, some of us really bore the brunt of COVID-19 very strongly. And at one given time, I think it might have really costed us some of us. I remember having been there. At one given time, I was deputizing the incident commander, and at the same time being the hotline, the person who takes all the calls from the people who might be in need of the services. And because of the lockdown, and most people were not able to move around at night. And people will call because they need an ambulance, and the call will always just take. I'll have calls together with my colleague Vicky. We'll be the one taking the calls the whole night, and in the morning we are to be at work in Kilifi. So you can imagine, and nobody really cares that you didn't sleep. And people, when they call, you end up using your own airtime to call back, try to organize for ambulances to move, particularly those women who are delivering from one point to another. And as healthcare workers, it's just clearly come out that sometimes we really frustrate one another. And that came out very clearly during that time. I recall sometimes trying to move a patient from one part of Malindi, which I cannot say because it will give out the exact person, or rather the people who might have really acted in a way that was inappropriate. Somebody tells you that you call the medical officer or rather the medical superintendent of another facility because that is in another sub-county. And you know, these inter-sub-county issues whereby somebody says, no, my border, that is I can only attend to patients from this and this and this place. So it was very difficult. You can imagine you are online, somebody is waiting somewhere for you to call back, tell them that an ambulance is coming, you need to reassure them. And some of them ended up even insulting us. They could use very vulgar words to ventilate their anger on us. Then come the issues of now being as an incident commander when my colleague, I think, went on leave. You can imagine all the calls coming in right from up, down, and then down, up, and sometimes all this involves movement of people. So it wasn't that easy. But at the end of the day, again, you're being told, okay, there's some people. I can really imagine what our sister there was going through being at Sajanad, being the first people who went there. All of us had fears, marshalling the support of the other mental health care workers to go and sit with them and try to debrief them. It's not that easy. It's not a matter of you just going there because and then coming out. Sometimes it is thought that as healthcare workers, or rather people who work in the mental health area, we are that strong to shoulder the problems of everybody. It is not true. We are also human beings, and what anybody else goes through is the same thing that we're going through. So for me, to this date, this is the first forum that I'm sitting in to discuss about what we went through. But if at all we're given a chance, I think we could write volumes and volumes of books or chapters regarding our experiences. What I just know is that nobody was really there for us, and it's really challenging that even right now as we speak, we've never had an opportunity to get a debrief and be told that at least you're doing a nice job and you deserve even a pat on the back. But at the end of it all, we were kicked out. And yes, that's a point. It's very painful to talk about it, but that's the reality. I may not really know what else really happened, but acknowledging the little efforts that we put that time, moving up and about, running up within the county and all, doing all that which we were doing, people at least need to be acknowledged. Even the little things they do, it's worth a lot. Because nobody gets paid for an extra thing that they do. But people give out themselves, they serve others with compassion, and some people are very passionate about what they do, and at times that's an area that we need to really acknowledge and appreciate. It doesn't really require you to give anybody monetary or anything, but even just a word really means a lot to individuals. So whatever happened, it happened. We don't pray for any experience to happen like that, the COVID-19 which we had. But in case such a thing happen again, I think the leadership should really understand that it is not...
Still analia. Akiwa peke yake anasikia nini? Those are issues that we need to discuss. Sisi kama medics. Nasema sisi kama mbele na comedy. We need to discuss those things. Ambazo tunaangalia, wengine hawajazungumza. Nikitaka nimrudishie yule kusema what ulikuwa unataka kueleza nini, lakini naona siwezi kumrudisha. Lakini nataka tu kumweka mmoja atuambie when they were doing this whole exercise, walikuwa wanahojiwa, what was that feeling? Manake baada ya time na feel kwa baada ya miaka miwili wakahojiwa. What was it? Nataka wewe ndio unakutaka. What was that feeling? Kidogo tu wagusie feeling zako, because it was baada ya time refu. Were you reliving the whole story again?
I think the play has made me now go back to those times and feeling like now I'm getting the feeling, a fresh feel. I really didn't want to talk Kalume.
Yeah.
Because I feel overwhelmed. And I remember my facility, I had a facility in Kilifi. So one of my workers got COVID. But because they were not, the community was not sure who has COVID. And that time, if you contacted COVID, then everyone looks at you like, now you've brought death to this community. So being a leader in that facility, I just received a call and someone is telling me, oh, Madam Wanzazi, I've just heard your name in the radio that you have COVID. And the whole village was like, Mnarani is a no-go zone because even the facility in charge has COVID. So that meant now no one wants to talk to me, no one wants to come next to me, not even my family members, no one will come to my gate to seek for any kind of assistance. And it was crazy. And to me, I will speak as me. I feel I have never given, someone has never come to me, talk to me, like given me a chance to express what I felt. Mentally stable to talk it out. I don't want to talk about that at this moment. I won't talk much, Kalume, thank you.
Hiyo tayari inatosha. Because it tells the thing about kukunaangalia that we have those burdens na hazijashughulikiwa. Nafikiri Remiko hapa ameona those things. I think something must be done. Au tunaona hakuna kitu ya kufanya. We are not late. Still we have time. Wale walioshughulika, they are our heroes, but our heroes are dying. Our heroes are dying. Nani ambaye atawasaidia? We need to sit down, we need to debrief, we need to have counseling session, we have to have trauma sessions for the people. Sana sana pia wasichana wetu, mama zetu ambao walipitia hayo yote. Ningetaka kuendelea, niwakaribishe daktari hapa achukulie kutoka pale.
Thank you, Bwana Kalume, so much for taking us through that session. Quite informative. Let's give him a round of applause. The next session will be led by Dr. Lisa Avery, and it is a panel discussion. But before that, one of the objectives of the Wheeler study was to check, to see whether there were differences in terms of inequalities, in terms of iniquities, in terms of experiences between the genders, male and female. As a male healthcare provider, do you feel, or how do you feel your experiences were any different from your counterpart, female? Or maybe as a paid, because tuliangalia paid and unpaid. Paid being the mainstream health workers, whether you are permanent or contract, and the unpaid being the CHWs. Kulikuwa na tofauti. Unahisi kama kulikuwa na utofauti kulingana na hisia zako ama experiences zako wakati huo wa COVID. Maybe we can just have two people, one male, one female, who can give their experiences and how they feel. Whether it be it at the workplace, be it at the community or nyumbani, in terms of the experiences. Chairman, kama mwanaume katika COVID era, Neville ameshare tayari.
So as a male healthcare provider, the question is, as a male healthcare provider, was there any difference in terms of treatment?
In terms of experiences as a healthcare provider compared to your counterpart, female counterpart.
me to talk as a male healthcare provider, or because yes, I love to, because that means that I have to know what the other partner felt. But all the same, I'll say that there is no major difference. There was no major difference in terms of treatment between male and female healthcare providers. But there was a big difference between paid and unpaid. Paid were treated relatively better compared to the unpaid ones. But for male, the gender, male and female, I would say there would be no major difference in terms of the way we were treating them. Because even in the deployment to the centers, gender was not a really big issue. We were not looking at, is this female or is this male? But in some instances, yes, in some instances, now I remember, males were more sent to the centers compared to females. Thank you.
Any female healthcare provider?
Thank you, Daktari. Me, what I will say is that the females, they bore the challenges of COVID more than men. From my experience, I was working in Kilifi hospital, and it happened that when a mother who was in labor and had the COVID came to the hospital, there were more challenges on where she will deliver. So, because the delivery room maybe has 2 delivery beds and we have more than 4 mothers in labor, it was very hard for the maternity staff to look for a safe place to keep this mother and deliver. And for men, the patients, it was easier because they could occupy a single bed where they can be isolated without a lot of disturbance. But for the females, there were a lot of challenges because of movement from maternity to the general ward to the postnatal ward. So I think I can say that the females had more stress when they were affected by COVID. And also, from the village level, if a mother got infected with COVID, she could not cook for her children. And this was bringing some gap in the care of the family. So I think I wish that in future we should look for ways to make the treatment equal for men and the females by providing more equipment in our hospitals. Thank you.
Anyone who feels they have a burning experience they want to share before we hand it over to the next panel?
I don't have a burning experience, but someone is there. Maybe he can experience. He can talk. My madam here, my sister. He has a very good experience which you have undergone together. Maybe you can have an explanation. Please.
I think I will take more time because of this story so long. About COVID, yeah. COVID ilikuja kwetu tukaipokea. We as a healthcare workers, we were afraid of getting the vaccine. Until that time when Mutaikamwe announced that nobody is going to get the salary until everybody gets an injection. So everyone was afraid of losing their job. I'm working at Magarini Sub-County Hospital, Maram Sub-County Hospital. nilipofika kwa station sasa niko peke nasikia na mpaka niko na riders, nasikia pain. Tulikuwa na my colleague nikamwambia mimi mbona nasikia hivi? Kwani kuna mtu alisikia kama mimi vile nasikia? Sasa kwani unasikia nini? Kama kuna mimi nasikia homa. Alafu at that time kulikuwa kuna mother in labor almost taking effect. Nikamwambia mwenzangu mimi nitaweza kuconduct delivery lakini akaniambia utaweza kisha nenda. So mimi nikaenda nikaconduct delivery, akaenda akaninunulia breakfast. Akanikorogea akaniambia hayakunywa hiyo utasikia nafuu. Then after 2 days I was okay. So nikaendelea na maisha kawaida. That day ilikuwa ni 15th of August 2021 ambapo tulipata kila mtu alipata hiyo first jab. Then nikaendelea after 2-3 weeks nilianza ku experience different. Yaani siwezi kubreathe. Nasikia tu nikibreathe siwezi, nasikia ya nyingine siwezi, yaani siwezi kubreathe. Nikifika usiku kulala siwezi kulala lakini mpaka nilale kwa sitting position mpaka nijiweke pillow. Mpaka bwanangu ananiambia kwani wewe si uende hospitali? Mbona una shida gani? Nikamwambia si nimeza dawa sahihi. Nimeza nilikuwa na azithromycin, nilikuwa na matangawizi na tafuna kila wakati. So namwambia tu mimi nitakuwa sawa. Lakini nilikuwa nashangaa kwani ni nini nasikia kwa mwili wangu. I'm not asthmatic but why I'm kufika nikaenda nikaonekana daktari akasikiza chest anasema je, nikaenda nyumbani. Hiyo Saturday nakwambia nyumbani kulikuwa hakukadiki, siwezi kuketi. Mimi nazunguka tu, yani siwezi kubreathe. Very nilipofika MO kunyona pima akaanza kuchukua hizo 170/120 SOP2 daktari akaniona pale akaniadmit, nikaenda star nikaadmitiwa. Kwanza how comes napata COVID? Akaniambia it is possible but X-ray wakachukua hiyo test ya COVID after 3 days COVID ikatoka negative. Hata sijawahi kuwa na BP more than 110/70. BP zangu the BP is very high. Then from there sasa daktari naye akashangaa kwani huyu anaweza kuwa ako nani? Temperature inazidi kupanda. Temperature nadungwa IV for IV PCM 4 hours. Then from there X-ray ndio akaona kuna hizo emboli kwa chest. Kuna hizo clots kwa chest. Akasema damu imeganda. The normal is less than 0.5 but yangu ilikuwa ni 1050. So daktari alipo sasa ilikuwa ni collapse. You know, damu yako yote imeganda kwa mwili. Nikamwambia daktari nini unaniambia? Akaniambia damu yako imeganda. Imegandishwa na nini damu yangu? Akaniambia sijui. But let's sasa from there sasa daktari akaanza akaniandikia hizi classini hizi group za heparin ambao nadungwa BD 40 international iko very painful. Mimi siwezi ni wakaniambia basi wewe sasa hivi utakufa sister. Afadhali ukubali. Then nilipokuwa naenda kudungwa bidii na nikaanza na anti na kunywa amlodipine sasa kwa sababu BP iko very high. So nikaekwa kwa hizo dawa almost 2 weeks. Then after the second week iko 0.11 maana yake less than 0.5 with the normal one. Ikawa ni 0.11 nikamwambia maana yake hatujajua cause ya hii damu kuganda ni nini. Then tukakaa pale nikiendelea na hiyo dozi akanambia maybe after 2 weeks utakuja tena tulicheck. Then nikadischargewa nikaenda nyumbani. So after 1 week na 7. So nilikuwa niko kwa nyumba daktari akinipigia simu njoo haraka hospitali. Kufika sasa daktari kwa nini anasema kidai masipata zimepanda zaidi ya zile mwanzo zilikuwa. Nikamwambia daktari kwa nini hii kitu inataka kuniua? Ni nini hasa kimekosa hiki kitu yote? So from there that discussion sasa second dose ya AstraZeneca. So from there sasa nikawa nimerudi tena hospitali damu imeganda, then nikaanza tena hizo anticoagulant sasa. Nadungwa bidii. Temperature zilikuwa zinapanda on and off. BP sasa aliponidisexa ndio akanika kwa anticoagulant. In fact nilipata complication mpaka sikawa siwezi kubreathe, nikawa natembea na inhaler. Up to now I'm using the inhaler. Alafu yani the platelets zangu mpaka sasa hivi hazijawahi kufika more than 100. Pia side effect yote ya mwili because uko high. Ukienda ukiivi utaambiwa your white blood cells ziko chini. So up to now I'm using inhaler na platelets zangu ziko very low. Blood up to now. So hii kitu hizi vaccines tulisema mia this are preventive measure but sometimes it is active. Imagine more than 10 healthcare workers, more than walidunga, but me
Let's clap for her, and I need to hand over the mic. So over to you, Lisa. Let's clap for her. She comes.
It's going to be a panel presentation, and I'm going to call up the speakers who will be part of the panel. But in keeping with what I've heard from more participatory, we'll do this in a new format. So the speakers will still come up, but we'll do it almost like a talk show. So I'll pose them a question, one or two of them may answer, and then we'll give out of the new format. I'm going to ask Lois, who's our community health promoter in Nairobi, Faust, who's mental health here in Kilifi, Machu, who's one of the from here, and Nuganje, to please come up and join us on the panel. And something the sharing of their experiences here in Kilifi and in Mombasa the other day is that I think not dissimilar ways. So the woman who was just sharing about her vaccine experience, I also had a similar. It speaks to the challenges we face as health providers when something's happening quickly. And you can imagine how scary that is. I had a young baby who was a year old and a 7-year-old, and I suddenly couldn't walk. I had been in the hospital and going up the stairs, I said, I can't get up this, something I never thought would happen. And similarly, I've been on medicine ever since. So it's not something that just happens here. It's happened everywhere, and it's had a lasting impact. Share and be vulnerable and talk about these experiences, because it connects us and what will make us stronger for whatever the next challenge is. I'm going to let each of the panel members introduce themselves. If we have a mic that we can bring up to the speakers, I'm going to move into the audience, or if they think there needs to be something done differently. Peter, can you please introduce yourself?
Thank you, Lisa. My name is Wanjovi from the Ministry of Health. I work in the Division of Health Research. One of our main objectives is Cambridge. Cambridge does the basic research, the science, but as the ministry, we coordinate with the division, the counties, the hospitals. They have to be authorized by the Director General, and we process that for his signature. Then we have a very the ministry as a whole and the health sector in general, we follow evidence-based decision making, also part of our duties. My specialty is environmental health and vector, where I used to work that way in the counties, or in those days it was district.
Okay, good afternoon everyone. I'm not new to most of us here. My name is Paus Ibrahim. If I'm to talk about my background, is that just like him, environmental health, but I took a diversion to, we had the Mental Health Council launched by the CDC. Maybe getting deeply for the first time, talking about our experiences, some of them very painful, or maybe this is a mental health wellness set up for the healthcare workers. Yes, we are attending to other people, but we don't have the helper to the helpers. So we are here to ensure that we institute mechanisms that will ensure that everybody is safe, and at least our working environment is conducive for all of us to be able to offer services in the most passionate way of giving some compassion, and it transcends to the others. Thank you.
Good afternoon. My name is Florence. I'm a clinical.
That's Community Health Impact Coalition. I'm also an advocate for community health promoters, passionate about maternal and child health, mental health, passionate about maternal and child health, mental health, gender-based violence. We are up to forming an association of their unpaid labor, and we have so many questions. Interactive session. Thank you. And we have so many questions. Interactive session. Thank you.
Thank you so much, everyone. Okay, so I'm going to Faz, you mentioned mental health, and you said, there's policies, and it's going to be support the mental health of our caregivers. We heard today that everyone here.
That pension. We don't really effort that has been made in that at least we don't really effort that has been made in that at least there's something that is in place. Kilometers starts with a step. So for the county acknowledging that there's a problem and management of mental health in the county, that's a big. It could be very personal issues from home, it could be workplace issues, and sometimes they don't really have a place to go and ventilate. We know that sometimes you ventilate to a colleague, and again it goes either the issues are misrepresented or they are used against you or used against an individual. So we are looking at forward to a situation whereby we'll have at least professionals situated in specific areas within the health facilities, whereby at least anyone who feels like challenged or have some mental health concerns can see someone, because right now even the county, in the county we have psychiatrists, something that we've not had before, and we are at some steps ahead, though we are not yet there. Yeah, thank you.
Thank you very much for your honesty. Does anyone in the audience have anything to follow up on that? Does anyone have a question? No? I do. When these plans are being made, are any of the healthcare providers invited to the table to share their ideas? And that can be to anyone on the panel. Do we include our healthcare providers, whether they're the community health promoters or the paid healthcare provider, when we're talking about their own mental health? Lois, can you speak to that maybe for us?
I'll start where it ended with the play. We actually played. The community health promoters, there was no non-existing support. Everybody was busy, but we were made to work. We were made to go and give services. We were made to go and give health talks. We were made to go and do tracing to our household, anybody coming in. The work was also in. We were made to report, but our reporting with our own resources. We were made to even mobilize for immunization. There's nobody for us. There were no PPPs for us. There were no better good trainings for us. For us, we were not even trained, we just being sensitized. That is what is happening in our countries. We should move. Just think of this and this and this. We were meant to be the watchmen and watchladies at the community level. We were meant to be the laymen. We did every work. Okay, I feel what the other cadres did in the hospital, but we were the first contact in most cases. how we do what protect ourselves. So it was inclusive, and I think all stakeholders, the county government, the national government, when we talk about community health promoters, think about us as women who are there, who are almost 90% working with mental health volunteering in most professionals. It's mental challenge we are there. It's about gender-based violence we are exposed. Because we're not doing even insecurity when we walk into any household. We're looking at what kids, who will look after us, who will hear our voices, and when will we ever be listened to, and when will action be taken. We are tired of the promises, we need action. Thank you so much.
Thank you so much. Does anyone in the audience have an action that they think would be important for the panel to hear that should be taken to help protect you as healthcare providers? Anybody have something they'd like to say on that? What action should be taken? Anyone have a thought? You can speak safely and freely. Okay, we've got someone in the front, the brave soul.
Thank you very much. I think listening to Fauz and also listening to the healthcare provider who was talking and the experiences that we have, all of us have very bad experiences of what happened after COVID. It's, I think it's important for us in the department and even the partners that would support to come up with a structured way of how healthcare providers should be engaged post-COVID. And I'm saying this being one of the first people who responded to COVID-19 and actually took part through, though we were in management. After COVID, we assumed that it is normal. So everybody went on with their life. But I can attest to what everybody is saying, that all of us have very bad experiences that we go through. We don't have social support that is there, that should be there to help us as carers for the patients to be able to move on. We have seen our colleagues, several colleagues have died post-COVID, and we know very well that the complications that they died of are as a result of COVID because they were in the front line, the frontline soldiers. Yet, we as a department, I'm saying we because I'm part of management, we have not come up with a proper way of handling healthcare providers who responded to COVID-19 and understanding actually what people go through and what actually even financially, what expenses people are going through as a result of getting infections at work. Yeah.
Thank you so much. You mentioned the need for structures, and Peter, you'd mentioned the need for evidence. So what type of evidence does the ministry need to be able to put safeguards in place for healthcare providers? The mic.
My name is Nabil. I just wanted to say this. Already, there's enough evidence what has happened during the COVID pandemic because we have lost healthcare workers in the line of duty, and more so the frontier healthcare workers. And I think moving forward, lessons learned, we need to have a very elaborate process to see to it the healthcare workers have been taken care of in terms of having a comprehensive cover kind of, because it becomes an issue when the very healthcare workers who are providing the services, they'll need those services because of maybe systemic challenges, they'll not be able to receive the said services. And therefore, there is need to have a special kind of cover for these very healthcare workers by design of the work they are doing. By so doing, we are going to protect them because they are protecting the larger population. And we cannot afford to do without a special kind of cover for us to be able to to provide the services. And to me, I think where we are going, it has not come out clearly how the healthcare worker or the front healthcare worker is being taken care of. Be it the community health promoter, be it the healthcare worker, who by nature of his work, day-to-day work is handling the clients or the patients. And that has to come out very clearly moving forward.
Thank you. Matthew, do you think as a provider that's in the A&E where you are often frontline as well, is that something that would resonate with the providers you work with, having some kind of comprehensive cover? Is that one action that could be beneficial or useful? So this gentleman had said, something that could happen that could be useful to help protect you as healthcare providers is to have, I'm taking it as a comprehensive insurance, some kind of insurance that protects you from a health perspective so that you're not struggling in case you fall ill, like a social health protection. That's maybe separate from the one that's currently being promoted. But is that something that as a nurse you feel is something that your fellow nurses would find useful, or is there something different that you'd like to be seen to be done?
I'll say 100% because as at now, we are in the shift thing.
Yeah.
And the preterm. Yeah. We have a preterm cover. Maybe I'll talk from my experience. It's not working. Maybe from my colleagues. What is your experience with the preterm cover?
Yeah.
It's not working.
Yeah.
Get it? So that is one aspect which, as a county, it really needs to be looked upon, because at the end of the day, if somebody falls sick because of an infectious disease like what happened with COVID, it was expensive treating. Yeah? If you, the patients who didn't have an opportunity to get ICU beds in our public facilities and had to be moved to a private facilities, the deposits which are requested, if that happens in the current state that we are in, then you can imagine the mortalities. Yeah? So something needs to be done as soon as possible for the healthcare workers, all the way down to the CHPs, just to make sure that they are covered. So very, very important. We need a comprehensive cover to make sure that whenever a healthcare provider falls sick, especially those on the front line, are well taken care of. The other thing maybe I should add is when COVID came, yeah, I was one of the surgeon at a hospital because of my background. By then, ventilators were now being introduced in the hospitals. So the few of us who had some knowledge on how to use the ventilators were engaged. But now there was a mismatch between the management and those of us who are actually taking care of these patients. In terms of, there was a gap in terms of the management being there, present to see what is happening, what are these guys, what were we going through. It was not good, but the touch between the management and those of us who are on the ground, there was some gap there. Get it? So going forward, I wish we could have the COVID experience as Kilifi County, so that we prepare for future pandemics. Recently, we've been being told to prepare, but you ask yourself, how far in terms of preparedness are we ready for these, which are very important, but they have not been taken care of. Number one is the issue of comprehensive cover. She's living with, so if the management will have a touch with a close touch and presence of what is going on, they should, they probably pick some of these things with an action plan. So I agree with my senior. A very good comprehensive cover is needed to make sure everybody is covered across all levels of healthcare.
In the midst of COVID, and there's shortages of all of the PPE, not just here, but it could be another pandemic. What do you think needs to be done? Need to be better communication? Does it need to be more presence on the ground? We can always say more money, but let's face it, we all know.
So the COVID experience, let me say, like when COVID came to the country at Machakos, I think we were 4 of us to be prepared. You've made your work plan, and the minute you step back into your facility, COVID is in Kilifi. You have a work plan that you've not implemented. You've not even given a feedback to the team that this is what we are supposed to do to prepare ourselves, but we do on a daily basis. So for me, get early events, so that peradventure something comes in, we don't have to start from scratch. We were caught very much unawares. And let me share with you an experience. So we come in, we are told COVID has come to Kilifi. We have not trained, so everybody disappears. Who is left? Me and Eric, who had been trained. And we prepared ourselves, we had the PPEs. So we come back to the office the next day, and everybody doesn't want to sit next to us. Health workers, managers. It was so bad till we had to force ourselves into quarantine, even despite knowing that we had all the PPEs, that everybody is aware of what is supposed to be done. In terms of human resource, in terms of capacity building, infectious disease, we can be able to just roll in. Then the other thing is we also need to have money. As much as you're saying money is not important, it is very important. Like for example, when they say now the policy has changed from spraying, and now we have to have this, without money we will not be able to do it. So I believe there is room for us even now, as we are anticipating the mpox, we need to up our IPC measures within the county, not only in the hospitals, but also in the community. This calls for IPC trainings to our CHPs, because we expect them to do some of we are task shifting to them, but you're not preparing them. Like she said very rightly, the trainings were given to healthcare workers. Very little sensitization was done to the CHPs. This time around, I think there's a need to prepare them in terms of IPC, avail to them also the commodities that they need, so that they also protect themselves and protect their families. So I believe there's still more to be done. So let's not wait for the pandemic to come and then we start running helter-skelter. Let us prepare ourselves, because we already know COVID-19 gave us an experience that we can work on, and we can be able to plan better for a future pandemic. Thank you.
Thank you.
There's a question here.
Question? Great. Just before we go to that, how many people in this room never had that before in my life? It's awful. Absolutely awful. Sorry, go ahead, Charlotte.
Okay, I have a question for Madam Luganje. Watching you are our eyes, telling us we are not yet ready for the other pandemic and we need to prepare as a county. Are you telling us now we are not ready?
We are ready.
After that experience now, what are you telling us?
What I said, I think
a question.
It's a question, yeah?
Yeah.
So what I said, if you heard me very well, is that we are better placed compared to COVID-19. COVID-19 taught us lessons. Like now we have PPEs, we have all the commodities that we need for infection prevention. But now we are talking about a pandemic. When COVID came, we didn't know how big the pandemic would be. We had all the commodities we needed. Didn't know how big the pandemic would be. We had all the commodities we needed, but they turned up not enough. So what I said is that we are prepared, but we need to think. There are lessons we learned from COVID-19 that we need to bring on the planning table, especially considering the CHPs and also making sure that we capacity build other people. We have had new staff who've come in that maybe have not undergone the training. Maybe our IPC material, IPC commodities are not enough. We are prepared, but we can better prepare. There's no time, even in your house, that you'll be, say you're 100% prepared. There's always room for improvement. So we are prepared, but there's still what we can do better. For example, when I hear people 3 years down the line talking about the experiences in COVID isolation centers and they're crying, it means we still have something to do. We didn't do well with our mental health support to them. So there's a need to take those people through care. They need to go and speak it out so that even if they're called to recant, they do not break down. So that is a gap. So there are many, many things that we learned during the COVID-19 that can better us so that we prepare for the mpox and any other pandemic that might come our way. Thank you.
I think Lois wants to say something. Go ahead.
I want to say something. I want to ask. Community health promoters are in the house and mpox is around.
We can't hear you.
Are you trained already? That's for community health promotion. Have you received any sensitization about mpox or something like that? Not yet. So that's what I want to ask Madam here now. You've said we've learned from COVID-19, and we were complaining we didn't receive that proper training. When are you planning to do the same to community health promoters? Because the community normally do ask us. They hear from social media, from the media that mpox is coming. What is this mpox? What can we be able to tell them? Another thing, during this crisis, how is Kilifi prepared to motivate community health promoters? Because stipends is already a problem. So let's talk about that motivation. You've worked, leave alone about trainings and everything. Are they covered when you're planning about PPEs? Are the community health promoters inclusive on your plans? Thank you.
Very good point. I think we know that the community health promoters are very much at the front line of all the work that is done and yet tend to continually be neglected. So,
okay, so the issue of mpox, even the healthcare workers have not yet been trained. So usually we get our command from up and it comes down. So we haven't gotten to the place where we are capacity building people. Later, not only CHPs, but even the community health, the health workers have not yet been trained. So the issue of the stipend, I don't think I'm in the place to comment on that. But what I know is that the government is supposed to give you a certain percentage, and the county government is supposed to give you the other percentage. That is, the other way that I've seen CHPs being motivated is when a partner comes and they're involved in activities and they're able to get something. Even for the county, when we have like polio days, when you go out for other activities, we are able to give something small. But I am not I'm not where I sit from. I don't think I'm the best person to talk about the issue of motivation for the CHPs. But we do appreciate you very, very much because we know what you do. And I've heard you say you're tired of being appreciated. You want money in your pockets. But I'm not in a position to be able to talk about it from where I sit. Thank you.
I think you raised an important point. You know, you want money in your pocket. Who doesn't want money in their pocket, right? I mean, I would like lots of money in my pocket. But it brings up the issue of unpaid labor, which also mentioned and referred to. And I heard someone speaking earlier, and they said, "Oh, I don't think it was different for a male healthcare worker or a female healthcare worker in COVID." But I have a question: who does the cooking in your house? Who does the cooking in your house? Put up your hand. Who does the cooking in your house? Who feeds your family? Yeah. Do any of the men do cooking in your house? And if they do, can you eat it? Right? But who looks after the children in your house? Yeah. Who looks after your like mother-in-law, like poor Teresa, even if she's eating all your mahamri? You, right? So came and you were still at the hospital, in the community, doing all those extra activities. Now the kids aren't in school, home, and people are unwell. Who was looking after? Was that still you? Were you doing all of that and still being at the hospital? So I ask you again, men, do you think the experience was the same? No. So then, Peter, and someone in research who is responsible for coming up with the evidence that then turns into policy, when we get the evidence, do we ask ourselves, is it different for men and women? Or do we just look at whether you're paid or unpaid, or a doctor or a nurse? It's a loaded question, but that's my job.
From the experience, I think for those who might have looked at the reports of some of the studies which were done that time, the experiences of, I think the women they had it rough. The cases of gender-based violence were very high. And you can recall being majority of, they are the ones who are doing lots of the works at home, that is domestic work at home. And I recall in one of the experiences in the talk shows, in the radio, in the TV, one of them was saying that it was even better that when people were going out there, the men were going out there to work instead of staying around in the house. Because all the time it's like they are stressed. Some of them were getting depressed. And also look at the number of suicides was also high during that time. So some of them could ventilate, or rather ventilate or become physical by projecting their anger on the people around them. So I think this is my personal opinion, though I may not really be having the statistics to back that up, but women could have had it rough more than the men.
Does anyone have anything they'd like to say from the audience, or comment, or ask a question?
I want just to give it's an observation that I've seen. It's like we have the right data, as according to the WIDA project, that these things have been happening. And with the talks of all the people are talking here, it's like it is there. So the thing it comes is like, what is our way forward?
Yes.
When you say about our way forward, I think we're not getting it so clear. A person like me, I'm a bit, I can't say I'm angered, but I'm frustrated. Yep. Why am I frustrated? Because it's like everyone is defending his position or her position. Why? Because when we are talking here, it's like there are issues that have never been solved. That is there. When we are here, we are talking about issues that have affected us, which needs to be solved. When we are here, we are talking about our lives, regardless whether you have a position or no position. Things happen to us. But when we are coming to solutions, no one is ready to give a solution. We are all blaming one side and another side. I think that is not the way we are supposed to be doing. We have studies, they are showing us. If we are saying that we are prepared, and then we are saying that we don't even have information on mpox, are we talking the truth? Are we talking the truth? Because if we are not prepared for the mpox, which is another calamity that is coming, and you are saying we are prepared, that when it comes, any calamity comes, we'll be okay. I think we are not. Could be I'm the one who is confused. Could be I don't understand the medical terms. But I feel there is a problem. Guys are here crying after 3 years. They need to be solved. And they say, we are okay. We are not okay. It's an issue of saying, we have known our problem. This is our problem. This is our problem. This is our problem. Though the thing now is that story of a mouse and the bell. Who is ready to go and put the bell on that cat? Who is ready to confront this problem and give a solution? Because other calamities are coming. And the way we are talking here, we will be there at that time. That is my comment. Sorry.
Thank you. Thank you, sir, for encouraging us. But in this, what I would like to say, in this study which we are participating in here is on COVID. We all know, many of us were either infected or affected, or even some of us died. So that's enough evidence for us to take action. But the action that we are supposed to take is the interventions are what we ought to now formulate. But they may not be, maybe your study will give us some ideas. But I have read some researches based on big data, but that is country population, like cross country, like globally, big data, all the people who are infected in various countries. So they were looking at the unit of analysis was countries. They found that the countries that were, even the rich countries, that the USA, the Europe, the poor in Africa, all were affected. But they found a certain finding that the countries that had proper trust in their government were able to deal with the pandemic better. Countries like the Eastern Europe, which are the authoritarian, the public trust the government, and maybe the governments are not corrupt, I don't know. Then other countries like the liberal economies like us, it was found that countries where communities are cohesive were able to deal with the pandemic better. So those are some of the interventions we may be able to look at. And strengthen community cohesion, like in Kenya, like the community health workers, they do a lot of good work, but still we are finding they are also exposed. But the communities, because we recognize their work, not just the Ministry of Health, even the communities see what the community health workers are doing, people to support them in their own small way, the counties, so that it does not become like we just expose them because they are good-hearted, they are able to volunteer their labor for the benefit of the communities. Thank you.
Thank you very much. But, looking at the deliberations, there are some three critical questions that come up. One, we look at the experiences we had during COVID-19. Then number two, we are looking at what strategies or what plans do we have that, learning from the experiences we had with COVID-19, that we can institute to counter such a situation in future, suppose it happens. And the third point comes in terms of we are working with a critical mass of people that we baptized them the name CHPs. Initially, we were calling them CHVs. They do very important job out there in the field, but when it comes to their concerns being taken care of in terms of remuneration, it is non-existent, or perhaps it exists in some way of allowances that comes with partners. So the big question is, what have we done, or what are we going to do about that? And I think that is what maybe we might be skirting around in terms of, are we really ready to face the situation of paying the CHPs, at least the stipends that are stipulated by the national government? Number two, from the COVID-19 experience, what do we have in place in terms of all those, can I say, the 7 pillars of health? I don't think I'm really competent to talk about the last two. But what I can say is that obviously in terms of the experiences, what comes out is that majority of us are still traumatized by what we went through during the COVID-19. I can say that for some of us who might have really gone through from the previous experiences, right from when we still didn't have the counties, you know, there was a way that you could ventilate, or rather avenues for one as a healthcare worker to get their issues resolved. You can start from the lowest level, go all the way to the national level, and at least get an ear. The question is, right now being in the county, it seems like everything ends up at the county. So there is no mechanism like an independent office that actually listens to the concerns of the healthcare workers or any other worker in the county. So apart from the mental health issues that can be taken care of with the plans that are in place, but what about those healthcare workers who feel aggrieved or hard done by perhaps the actions or reactions of the people who supervise them? So these are some of the things that perhaps I feel are of great concern. Do we have, when we talk of the County Public Service Board, can I rush there if I have an issue with my boss? And suppose the leadership there align themselves with my boss, where else do I run? So personally, I think there'll be need for the county to institute like a mechanism, put up, just like we have the office of the ombudsman at the national level. We have such a thing in place to take care of the workers, not only the healthcare workers, but anybody else who's working for the system, that at least you can go there and have to discuss your issues so that they can be resolved. For the mental health, yes, the county is trying to do something. We might be slow, but at least there's something coming up. And I really appreciate that. But when it comes to emergencies, the question put by our colleague there, yes, we have an emergency system in place, but you can attest, all of us, COVID-19 was a very new phenomena. And you can recall that Kilifi County was the first to be mentioned all over the news regarding COVID-19. So the challenge was really enormous on our side. And none of us can say that we are experts by then regarding how to go about it, because I remember when during that time I had to escort a colleague who was not doing that well back to their home area during the lockdown. And the experiences we had, every time we could stop by those roadblocks, and people will literally run away from us because they thought we were all infected. So when it comes to how do we deal with an outbreak of a condition that is completely new, I think this is not something that we in our position can be able to come up with a way of how to go about it. Because normally the ministry, or rather the government, has a structured way of going about it, and it's normally trickling down. This, unless counties are allowed to go completely independent from the national government when it comes to dealing with phenomena that are new. So for MPOX, I know there is the IDSR is dealing with it. IDSR, I think it's he must be really aware about it. Right now, there might be some brochures that are posted and some reports, weekly reports, just like the way we had COVID-19. Perhaps the way COVID-19 was announced, the way the information was, the news was brought to the public, is not the same way as MPOX. So maybe it's not been given that much of attention. But all in all, I agree with all of us that we have to put mechanisms and be checking all the time that it is working and always ready in cases of emergency. Thank you.
Thank you. I'm going to segue towards closing this session, and I'm going to follow up on what Kalume said. And can we come up, each one of you, with one key action you think would be a good thing to try and do to help us be ready for any emergency? You know, you'd mentioned mental health. Okay, we've got a policy, but what's one key action that needs to happen aside from having a policy? You'd mentioned infection, preparedness. What's one key thing? You'd mentioned not having communication. Is there one key thing we need to do from a communicative perspective to make sure that this doesn't happen again? With the CHPs, what's the one key thing that from your perspective you think needs to be an action, not just words, but an action, a hard action that might make a difference? Same with at the ministry level. It's interesting hearing this interplay with devolution, because you national level that they're there as technical support, but then from the county level you hear, well, it comes from the top. So maybe an action is that has to change. I don't know, but I'm asking each and every one of you, and you can decide. We can start with Lois and go to the left of her, but what is one key action that you would like to see based on the role that you play in the health system?
Right. action points, first of all, I'd like to urge both the county and the partners, we need to be included in those roundtable discussions. We need to be part of the planning. We need to be part of I think we can tell the story better. I think we can say it better because we are better placed with the community. Better, we are better placed, and we are doing it passionately. If we can do it without being paid. I think it's going to be a game changer. You're talking about, I can see the Sandia County, they're talking about promotive and preventive care. That's something that is coming fast for anything. So I'll urge you all to invest on promotive and preventive care because I think it's better a story, just in few lines. 10 years ago, there was a campaign on a cervix. When I went there, she told me, Lois, do you know what? There's a campaign. I was asking her, what about the campaign? And she told me, do you know what? It's when you've been screened, you take a friend for this caution with my colleagues. Why? I haven't taken anybody. When I went there, I hardly cervical cancer. I could sit, read I could read the stories and everything. Or anybody closer to my family. I could see it will happen with other people outside there. So when she took me there, I was like, the first thing that came into my mind was cancer. Any problem, I don't feel anything. So I walked in, just because she's a friend and I want to satisfy, I said that we can go for lunch. Yeah? So she told me, do you know what, when I went for the screening, there was a mass there, they took the biopsy, they've sent it to Aga Khan, and I'm waiting for the results. And she's okay. So I'm asking her, do you feel any pain? No. Do you feel this? No. Do you have any discharge? No. So I was wondering, even me, I'm okay. We're just wasting our time. So when I walked in, the personnel screening were like, Lois, your cervix doesn't look good. And I was like, my goodness, what is not happening? See, I'm just okay. And they told me you need to come and see the guy on a Thursday. It was on a Tuesday. Because they're seeing something. And to me, so many things started running. First of all, I'm a community health promoter. I don't know this. So she told me and they told me not everything that looks like this is cancerous. So just I had 2 bad days, 2 bad nights, because now I was thinking about cancer, and what cancer is. It's a death sentence. When I went back, the doctor told me, yeah, looks like your cervix is not good, but we're going to do the biopsy. They took out the samples, they sent them. Positive, but they were precancerous cells. I came back to Nairobi. I went to Kenyatta. They did the lip and I made the follow-ups up to 3 years, and they told me I'm cancer-free. There are no other cancerous cells. I remember having 2 of my close relatives that I wanted to take to just as friends. It wasn't anything serious. It was like, you've been screened, bring a friend. And they said no. Yeah? When they said no, like a year ago, one started bleeding, but she didn't say. She kept it to herself because of that cultural, regional, and traditional beliefs that women don't want to go and get screened that easily. Later on, they called me and they told me, Lois, there's a time you told us about this, but we didn't get it right. And I told them, no, you can just go and see the guy. This is the guy I saw. When they went there, the cancer was at stage 3, the same cervical cancer. The other ones that came some months ago, the people that I told as relatives and close friends to go and do what? And I was wondering, if I could have said no, those are 10 years ago, to my friend that I don't want to be screened, what could have happened? So that's what we want to do. The cancers are at the rise because people are not sensitized properly at the household level, at the ground level. Women are dying because of this. And that's why I'm talking about prevention and promotion. More, I'm okay. I'm cancer-free. I go for the screenings, and I love doing it. But what about the others? I believe if the 2 could have gone for the screening, they could have been okay, the way I am okay today. So kindly invest on preventive and promotive care. Another thing, just equip us. Train as well, supervise as well, and if possible, give us salaries. Our work is tangible. We are working and we love it. Just salary us. Yeah. And join us in the campaign. before I pass the mic, CHP is in the house, we need to meet. I'm the treasurer, ACHVOC, that's the Association of Community Health Volunteers of Kenya, and Kilifi is missing on board. I'm very happy to be in Kilifi, and I love to interact with you. Thank you so much.
Thank you very much. Very, very good points. You want to be included, so included. Bring you to the table. You want to participate. You want to be recognized. Okay, Machu, what's one key action you would like to see?
Yes, maybe to pick it from where she's ended in terms of preventive and preparedness. God forbid, and maybe I'll pose these questions to you guys. God forbid, if COVID comes back again, ask Kilifi, in a scale of 1 to 10, how are you prepared?
It's a good question.
Because SARS-CoV infections are, I mean, these are things, the viruses keep on evolving, but God forbid if it happens, maybe I can get 2 responders. Pardon? 2 over 10, isn't it? So, yes? I can hear 1.
Who's saying 1? Who said 1? What makes you not prepared?
I like to hear the person who said 1.
Who said 1? You said 2. Okay, tell us why 2.
I think at an individual level we are prepared, but at a health system level, I doubt if the current...
Sorry. You can't say we are prepared, then at an individual level?
Yes.
No. How the county itself, how is it prepared?
I'm coming with my point. Health system is political, and the reason I'm saying it's political, as long as we don't have health service commission, that thing would work. And if we leave health service in the wrong hands, still we'll face the same challenges in health system. I'm sorry to say this, but if COVID happened in the current structure, I leave you guys to answer that question. I think in the previous government we were well prepared, but now, mtajibu.
Yes. Does anyone else have some? 1. Okay, go.
Yeah, for me, I said 1 because I feel, especially for those who went to the COVID center that the previous time, I don't think there is any who will accept to go back to the same situation. And for us who have not yet gone, I think even if we are healthcare workers, everybody will look for a solution or for a problem which will make her not to go. Because I feel, apart from the comprehensive medical cover, we also need a compensation method in which, if today I die during the pandemic season, I'm caring for people, want my family gain, want my young children gain. At the end of the day, we talk about others, who thinks about us. The minute people will start thinking about us, then I think the system will be in a better position. Also, when you look at it right now, the workforce in the health system is down completely. So today, even if those people go for quarantine for 14 days, we will be left in these facilities. I think very few people, and that is what is happening. Yeah, and for the CHPs also, I think they will not be comfortable because last time, from the previous experience, then it will hit us too much for us to accept to do it. That's my point.
Well said. Machu.
Yes. So I think that speaks a lot. 2 over 10, below average. Yeah. So that speaks a lot in terms of the work that needs to be done, in terms of preparedness. Preparedness in terms of infrastructure. If we go down at the community level and you start looking at it at the community level, the dispensaries, if you get an infectious disease there, how well are you prepared at that level? Yeah, those are some of the questions we should start asking ourselves before we start calling the focal person, the sub-county managers, all the way to the heads of divisions. I mean, how are we prepared at that small community level? So this preparedness is holistic in terms of the trainings, the supply of PPEs, pharmaceuticals, all the measures that are supposed to be put in place. Then again, should we start off thinking of a checklist or how a tool to measure our preparedness, something like that? Because when we say 2/10, that means there's a problem. So we should be thinking of a tool of preparedness in terms of infrastructure. Do we have the infrastructure? Trainings, engagement of the CHPs, trainings, infection preventions to across all the cadres, the supplies, pharmaceutical, non-pharmaceuticals. Should we be taking this checklist every quarter? You get it?
Yes.
Just to measure how are we prepared? Because it's so unfortunate that when it happens and we are at 2/10, and you can imagine the number of deaths. You get it? Still on preparedness, a checklist on the mental aspect. Do we have debriefs post these pandemics? It should be in the checklist. Then having, again, a connection between the management and the people at the ground level. I'm so much interested in that because during COVID, we personally, I really missed that. That gap was so big. So let's think about it. 2/10 is not good, and we can do something about it.
Thank you. Really good points. And I think it's very powerful to point out it's not just our health system that's maybe not prepared, it's all of us as individuals that aren't as prepared as we should be either. Luganje, your action point.
So most of the things have been talked about, I don't want to repeat, but in a nutshell, I think this time we need to look at every pandemic using the health system framework, where we look at everything using the pillars of the health system. And one of the strongest pillar is the health workforce. But the others are equally important because for a health system to stand, all the other pillars have to stand. If you trip one, the system falls. So why am I picking on the health workforce? What has come out from what we have talked about this afternoon since morning is that our health workforce is hurting. So we are not prepared for a second pandemic. So we need to heal and take care of this health workforce, both at the healthcare worker level and the CHP level. We need to deal with them. They're hurting, and they need to be taken through sessions so that they can be able to debrief and also be able to heal. Because they're the same people that we are expecting as our soldiers to go to the battlefield, but they're hurting. Some are still crying when they recount, some don't want to speak. So it means there's a gap there. So for me, that is something that we need to do before we get to the next pandemic. The preventive, promotive has been talked about, I won't repeat it. But for us, if a pandemic came at this moment, I can see that we'll have a problem with the pillar of the health workforce because they need healing. And we need to move into it as soon as yesterday, so that we arrange sessions for everybody who went through for debriefing and also to be taken through so that they can be able to be ready for our next pandemic. Thank you.
Great point. So actually making sure that we're looking at their mental health now and offering them what's needed before waiting for something else to happen. That's a perfect segue to you, Fauz.
Thank you. My key action point. I know we generate a lot of data as healthcare workers from the lowest level to the highest level. And one thing that maybe as a country or as a county, we really need to work on is to make use of our data. And that data that we analyze should inform our decision making. I know that if data is utilized well, right from the lowest level, at least it can help us institute mechanisms that will avert crisis that occurs, just like the COVID-19. We might be talking of COVID-19, yes, but there might be other conditions that are there in the society that we're not able to pick them just because perhaps we generate the data, submit them to the relevant offices, and they are maybe posted in the system that is available nationally. But then we might not be really taking our time to look at those data critically, make a meaning out of it, and let it inform our decision as a country and as a county. Thank you.
So using data for decision making. Okay, Peter.
Yes, I think I would also like to align my colleague who said about the human resource management, because as we have seen, are being performed here by our very able actors. There is an issue of health workforce issues, and to cure that, we need the other pillar. Health workforce is an important pillar, not a pillar, it's a building block. Eh? But this is the without an accountable and transparent leadership. So those of us who are leaders, whether it's in a dispensary or a community health unit or a hospital account or a national level, you are still a leader. And your people under you, we need to, first of all, lead through transparency and accountability, and take the welfare of the workers seriously. For example, by implementing the Ministry of Health Workplace Wellness Guidelines. For example, every workplace, even a hospital, you are supposed to have a wellness clinic for staff, and not just a place where they are issued with the painkillers, so a place with the diagnostics and even therapeutics, like counseling, for people who may have post-traumatic issues like the ones that arose from the COVID. And we saw the testimony of our lady colleague there that she's living with the physiological damage from that, or pathological damage from that pandemic. If you have such a service which is free and accessible to every member, whether it's at OneNet or community health worker, volunteers within the workplace, are able to get that kind of support. Thank you.
Thank you very much, everyone. I'd like to ask everyone to give our panelists a round of applause. I think they've been very gracious and asking questions that weren't all of you stand in the way of you and food any longer.
Thank you so much, Lisa, and to all of you again. I think when we were starting off this study 2 years ago, we opted to go the participatory way, right? So, and this was a bit different and scary for us in terms of how would we not show the p-values, the confidence interval, and make it so researchy. But at the end of the day, I have seen the power of storytelling, and I do advocate for researchers in the room. It's quite important for us to not only show the charts, the p-values, but also tell the story. Because behind every research, there's a human being, right? Human research. There's a human being who has told you the story. And we have tried through the Wheeler study and through the help of SAFE. Thank you so much for telling our story and telling the story of the healthcare workers in the room. So I was to give a summary of the key action points, but I don't want to belabor on them because you have heard them time and time over again. So for us was to create a platform for dialogue. And this should then hold accountable to the county government seated within this room. How do you continue this momentum? How do you ensure that whatever has been promised is actually delivered to the healthcare workers in the room? The other thing is the importance of zooming in to the healthcare workforce, right? They are our soldiers. So when you go, people who are raised in, I don't know, armies or whatever, you know how they always prepare, right? They prepare the armies and for any war. So are we preparing our healthcare workforce as the armies within the healthcare system for any eventuality. CHPs to be at the center of it all. So we need to run away from the traditional, calling them for a meeting, having CHPs, you know, we need to train them, we need to have them around the table. And that has been emphasized a lot. And I think there's a lot of literature that emphasizes on the need for community engagement in not only naming them, but also making them meaningful partners in our conversation. Access to care. We all talk about access to care when we refer to our patients, right? We say access to care, the women need to have enough transport. We never look at within ourselves, and clearly we have challenges to access to care within the healthcare system as healthcare workers. How then should we improve the access to care for all our healthcare workers in terms of the healthcare services, as well as the ability to access those services? The wellness clinics, they're not there or they're not functional at the time. The bridge the management and frontline worker group, and I think this has been emphasized and I cannot belabor on it. Continuous preparation, and so far we have seen our systems are very fragile, right? So we need to be very cautious as managers in the room. We are working with a system that is almost breaking apart, and without the healthcare workforce, it may be very difficult for you to push the health agenda forward. So it's very important for you then to address the fragility of this healthcare system within Kilifi County. Then we were lucky to do these studies within two contexts. So there was Mombasa and there was Kilifi County, right? And what has come out clearly as context-specific health system priority for Kilifi County is healthcare workforce. For Mombasa, it was more of health financing, right? So it is important for you not only to look at the recommendations in the lens of what has been done globally or is being done within Kenya, but look within yourself. What is the story, what is the data telling you? So for Kilifi County, context-specific solutions to take care of the healthcare workers ahead of you. The issue of community engagement, political commitment, and community trust. And I think there's sufficient literature to support this. Without community engagement, without community trust as a context or structural foundation, you cannot have community engagement. And without political commitment to support what happens at community engagement, nothing will move forward. Similar to UHC, as we are addressing the issue of SHA, SHIF, whatever we want to call it, right? If the community would not trust us, if the community are not engaged, so in as much as you have all the political commitment to UHC, you will not be able to deliver UHC unless you fix community engagement and community trust. So that goes beyond the scope of our study, but I speak also as someone who works for Kilifi County as a healthcare worker as well, but as a researcher. So for research, an action point for us is how do we make sure that the data we collect, the evidence we collect, tells a story and creates change, okay? So we need to run away from the traditional, I know we have manuscripts, right? We have slides and all those things, but we need to make sure that we tell the story and create a platform for which people can be able to relive or even walk through what actually happened and validate your findings. For Wheeler, having you all around and validating the findings through the play that was placed is an important step. Creative, it is, thanks to a knowledge broker, but it was equally a challenging and time-consuming, expensive, so to speak, but it's something that you can always learn from other researchers. So I'm happy to see my colleagues from other institutes within Aga Khan present here so that you can also learn how best can we utilize research or how best can we do community participation research going forward. So with that being said, I would like to sincerely thank each and every one of you for being here. Aga Khan management, Grace and team, thank you very, very much for all the support. Nora was there when I was submitting this grant at 9 p.m. I was seated with her and she helped me push the button. So thanks to you so much, Nora. And to every one of you, the healthcare workers. I was also a healthcare worker during COVID-19 pandemic and I experienced what you experienced. And it's so fulfilling for me to say that I am advocating for the health of the healthcare worker, okay? Let's promote the health of the healthcare worker. I am doing it best as a researcher, but you should also do it best as a healthcare worker. So thank you so much, all the healthcare workers, the managers, the government decision makers, Dr. Bilali, Dr. Adam, who's not here from Mombasa County, and the CHMT at large, and the research team for being very, very supportive. I'm so happy to see my former research associates here with us, Sheila and Joel, they were here, but they have moved on to other entities, but they still feel like they are part of the family. Thank you so much for making time to be here with us. Irene and my co-PI from Canada. I wouldn't know anything about gender-based analysis plus if it were not for University of Manitoba. So my capacity has been built in terms of doing research better, but I'd like to share this capacity and this experience and this expertise with all of you. So feel free to contact me, feel free to reach out to the Wheeler team. I've been told our QR code is not working, but the website is wheeler.co.ke, or you can find out details through the Aga Khan University Center of Excellence Women Child Health website. Thank you to each and every one of you, the Knowledge Mobilizer, Ginny, Safe Community, asanteni sana sana sana, that tuko pamoja. As CHPs, you have been very, very instrumental in moving this agenda. And I'm so happy that there's actually, through this study, you're making a link with the advocates of community health promoters. Coast Province has been missing out, but through Wheeler study, you then be part of the association and have that movement of bringing community health promoters together. So let's all work together within our different efforts, within our different expertise, to make sure that we improve each other's lives. Let's not make each other's lives difficult. Thank you so much.
So we now would like to invite the research coordinator to speak on behalf of the department, and then to give their vote of thanks.
Thank you so much, Dr. Bilali. Wow, good afternoon, everyone. It has been a fruitful morning, and I'm sure it has not been in vain. It's one thing to invite people, it's another that they show up. We didn't expect a full room. I know people are engaged all round, but you've showed up, and I'm sure you've gotten something out of this. Not to forget Eva. She's been one of us. She came back with a study and decided that she's going to do it here in Kilifi. We've not only been capacity built, you've done well, my dear, and we thank you so much, especially with the methodology that you guys chose, the human-centered design, which was a participatory approach. I am sure you had your voice. In one way or another, you had your voice somewhere, and it's something that we need to applaud. A round of applause, please. We've learned something too. Last year we had our research conference, right? And we said that we are moving from research to implementation, and we are also advocating for getting feedback when we do our researches. This feedback, not only at that level where it was done by the PIs, but from the voice that gave that data. That is what happened here today. Yeah? So I hope we've picked something. Much might not be able to be done by us seated here as a system, but it starts with me, it starts with you. Yes? So that is something that will start with me, and it will start with you. We've learned so much. We are all hurting in one way or another. Some of us didn't speak. Not because we were not there, not because we did not experience anything. We might not have been infected, but for sure we were all affected, all round. Everyone was touched in one way or another. So can we be more sensitive to each other? The results in Mombasa County, as Eva spoke earlier, what was coming out was healthcare financing. It came out very strongly. But for us, it is us. The human resource, it is us. So I'll urge all of us to be more sensitive to each other as we collaborate and as we keep on working together. Thank you for the feedback. We are going to take the feedback further. We are going to advocate for it in one way or another so that we see changes. They might not be huge, but we will start with us, small steps, and we shall reach there. So thank you so much for everyone who's been here. Aga Khan University, University of Manitoba, we've walked this journey together. We've been capacity built, we've learned a lot. Tulichoka. tukifikiria. And our ideas were taken up. This is something that was just as a discussion. How best can we be able to give this feedback? And it just came out. What if we try a skit? We didn't think it would go this far, but we've seen the product. We've seen the fruits. And that is what we want all of us to be at. Let us be more creative, not only in giving out numbers, but in giving the story behind those numbers that we have when we give out our research findings. So without further ado, all our CHPs in the house, asanteni sana. Tulisema tunaanza na nyinyi ndio tufike sisi. And we saw we cannot do without you because our human resource is constrained. Yes, we all agree. We need to do better. We speak from one page and we all sing. MedSoups who've been able to reach here also. The whole team, Aga Khan University, Jeannie, the genius behind all this, by the way. A round of applause for Jeannie. She was the knowledge broker, and she took the ideas and she made them, she got something out of them, yeah? The SAFE team. The SAFE team. Sijui kama wako? Hey, one of you cried. Thank you so much for internalizing those findings. You really internalized what we wanted to be brought out. And it touched so many people here, as you could see from the feedback that we got. Asanteni sana nyote, our communication team. Owen, there's a team, Youth Voices. Asanteni sana for being here. They've been working with us. There's Nora, Maura, hi, yes, Irene, oh goodness, tumemsumbua. Yeah, she's been part of us as Kilifi. Thank you so much. All the in-charges who participated in this research and the feedback that you gave us, for being open, for being vulnerable, we do not take it for granted. We really appreciate you all. And I hope it will not stop here, but we shall take it forward and be better people. Without further ado, I'd just like to say thank you to all of you, and God bless you all as I return the mic to Dr. Bilali.
Thank you very much, Dr. Tumpe. Maybe the only thing that can be said after that is a prayer. So the Kaya elder in the house, get ready. Just one announcement. After this, we will all have a group photo outside the hall. So cameraman, get ready, get ready, get ready. Nani atatufungia kwa maombi? But lunch is served inside the hall where we have. Miriti, unajua kuomba? Sijawahi sikia ukiomba tangu nikuje department. Karibu sana.
Good afternoon. My name is Meriti, as you have said, and let us pray. Father, in the name of Jesus Christ, we come before you this afternoon in Thanksgiving. We thank you for the fire you have taken us, King of Glory. We thank you for the brains that came up with this, for the fire gone, King of Glory. We are praying that God, the revelations that have come from this study, the findings that have come from this study will be of help to the people of Kilifi and to the people of Kenya at large, King of Glory. As we depart, we pray that God, you are going to give us journey mercies. We are praying for the lunch that is going to be served to us. May you bless it, King of Glory. For this we pray, believing and trusting in Jesus' name.